Okay, so there's 104 slides on this, and while I wanted to get rid of half of them, and while I did get rid of half of them, I had to start over because in finding out everything that I found out about all of the miscommunications, I've learned that there are a couple of you that need to know the things that a lot of people with a little bit of medical experience would already know. So I'm going to review all slides because all slides are going to talk about some basic things in the beginning, and then it's going to work up into a bigger storm of information. I don't want anyone to be freaked out. This is okay. This is for supplementation of your comprehensive overviews. These are meant to enhance your understanding of learning experience. So if you miss these, you're missing good information that you need, and you need to review it later. But is it the end of the world if you miss all of them? No, it is not. Not at all. This is meant for you to just kick back and understand the composition of the body system and what that looks like. And it also includes pieces and parts of anatomy and physiology and a review of Latin. All of these things rolled into one because I want you to enhance the way that you understand the world of nursing around you. All right? You're going to be a stellar nurse. And everyone gets freaked out about me. And I've told you guys this. A couple of weeks in, you're going to be really, really nervous. You're not going to know what to do. We're 6 weeks in. And I don't have you for just a semester. I have you for the next however long you're here, right? I think it's 18 months for you guys. So it's going to be a little bit of a different experience in my position because my position is to be with you always. Sometimes in spirit, sometimes over a text. But I'm that guy, and I love being that guy. And part of me love being that guy means that I'm going to give you more time and attention, and I'm going to do a lot of extra things for you. And you're going to think that because I'm doing extra, it means I'm requiring you to do it. And I'm not. I'm trying to get you to understand the depth of nursing, which is why I talk a lot about my experience as a nurse, my patients, and the typical patients I get. Why I talk about how I was raised, because the things I'm trying to teach you is how to look within yourself and understand your cultural narrative and understand your environmental narrative, what that means to you, who you are on the inside, and how you're going to appropriate adding in the idea of being a medical professional by way of nursing and balling it into one wonderful bit that just shines brighter than the sun. That's how this works. So this is not a requirement. And I'm so ridiculously sorry that I did not articulate that a little more firmer. That's my mistake. But please understand that. We're going to do great. We're going to fix all of this anyways. But this is how we need to study. And I think I actually, over the weekend, if I have some time, I would like to maybe, I think it would be a good idea for the next cohort coming through, that what I can do is I can add a lecture on how to study for my exams. So that way it's there, it's laid out. Tell me what you think about that, because I'm actually really curious. And I'm going to edit over these for the next cohort so they don't hear any of this, because I wouldn't want that to play. But for the purposes of right now, I want to hear what your thoughts are on that, because remember, we're a team, right? Like ducks fly together. And we're ducks, right? That's how you do this. And I say the duck because being the duck is very important to me. It's a phrase that I use often. Being the duck. What does that mean? Well, what does a duck do? A duck coasts on the water with the beautiful sunrise that's hitting the water, and it's glistening, and it's like glittery, and it's beautiful, and little beads are coming off of its feathers, and it's so majestic and magical. Now, I pose another question. What is that duck doing up under the water? It's kicking for bloody life. That's what the duck does. And my friends, that is what it is to be a nurse. That is what it is to be one of the savers of humanity. That's how you do it, because that's how it's done, and that's what a nurse truly is. And we, somewhere along the lines, have forgotten that. So, I propose that we take the glory days of yore, we take the new way of doing things and approaching things from a technical and scientific standpoint, and we smush the two together to make one mighty fantastic hamburger. I'm just saying. And the meat of it is you understanding what it is to be all of these things by way of these supplemental secondary lectures, and having your primary as your primary mode of content, and understanding how things go as articulated to your book. I hope that helps. So I'm going to give you a very robust overview, because again, you might not watch this right now. You might watch this 3 days from now. You might watch this 6 months from now. Heck, a year from now, you might need to go back to it because of the exit HESI has so much health assessment in it. You're going to want to start to review it early so that you kill that exit HESI, right? I'm all about strategy. I'm doing this now because I know in a year you're going to need it. And I'm all about you. My entire world is about you. And you haven't figured it out yet, but you will. I'm going to be that guy for a lot of things. You'll figure it out. Ask your students. I know that you guys are intimidated by asking the other students. When you run into the other students, go, hi, real quick. What do you think about Professor Molly? And then just zip it and see what happens. My reputation is all that matters to me. And I work hard to get the clout and reputation that I have. And I do it because you are all that matters in my world. When I'm at work, it is all about you. When I'm at home, it's going to be about you. It's about you right now on my day off. And I'm happy to do it because I'm happy to form my legion of fantastic nurses that are competent, that are witty and funny and comical and a joy to be around, and that are refined from a very, very rough exterior, but now smooth as a pebble that's been on a beach for 1,000 years and shines brighter than all of them. That's what I'm trying to do here, and you're part of that. So let's get to the next slide. I spent 7 minutes on this one. That's a record. And let's look at things a little bit different. Let's have fun being a nurse. Let's have fun being a nurse. This is what it is to have fun being a nurse. All right, now, concept overview of what we're going through. We're going through head, ears, eyes, nose, and throat. So this is a lot of coverage, which is why it's 104 slides. So this one's a pretty simple slide. So concept, sensory perception, sight, hearing, smell, taste, touch. A couple of caveats about this. The last thing that you lose before you die is your hearing. So if you ever have a patient who is passing actively, speak to them, sing to them, let them know what's going on. Because not all of them die. Some of them, some of them come out of it every now and again. And they tell you about it later when you're completely baffled and have no idea. Case in point, I had a patient with a midline shift so large that they went off on hospice. And I told her goodbye. I had her for 6 days, and they were trying to see if she was technically brain dead or not. And they were going back and forth and on forever. She wasn't technically brain dead, but she had such a severe midline shift, it wasn't going to be very far until that happened. So they took her to hospice and expected her to die in the next week. Well, 7 months rolled around, and I had a very familiar face call me from behind and go, "Oh my God, Molly." And I turned around and I said, "Oh my God, how are you?" And it was the son. And I said, "Okay, cool. How's mom?" Or how did it go with mom? Like, how was the experience? Or no, I didn't. I didn't say anything. I was just surprised to see him. And he goes, "Mom wants to talk to you." And I said, "Huh?" He goes, "Mom, she's over on the bariatric unit. She wants to talk to you." And I was like, did I get the wrong patient? Because I swear to God, this is the right guy. And I just looked baffled. And he goes, just come here. Just come walk with me. And I was like, but I don't understand. He's like, "Just come walk with me. Don't say another word. Just come walk with me." So he walks me down the hallway to the bariatric unit, which was at Miami Valley. It's on the opposite side of the neuro unit, on the progressive care unit, because I was there that day when I bumped into him. So he walked me over to the bariatric unit across the hallway. And I walk in the door, and I just kind of looked at him, and I looked at her, and I looked at him, and I looked at her. And I looked baffled, and I said, "Hi." And she goes, "Oh, Molly, I've been waiting to hear from you." And I was like, oh, I totally just lost it. And I said, how on God's green earth? You were out, you were conked, you were done. I was 3 years a nurse. I felt really confident in my abilities to do things. I worked with neurologists and neuroscientists and neurosurgeons for 3 years at a very, very fantastic hospital, very prestigious, very large, level 1 trauma, helivacs and all. And I was just baffled. And she goes, oh, you sang to me. So I would walk to your voice. And I would see what was going on around me. So, sorry. So, whenever I would hear your voice singing, I would know that I could go to this place and I could see my family. And I didn't know what was going on, but I didn't care because it was fine. So basically what she told me and confirmed for me was that there is another side. She heard me, and she was transitioning between life and death in her case. And in that, she used my voice as a way for her to walk to the side again, because she was getting closer and closer to the left side, to be on the other side of whatever's there, right? So keep that in mind for hearing. I don't think you'll ever forget that again, because it's that serious. You might be the reason that they're able to walk over to this side again and see their family one more time. I want you to think about how powerful that is, to say that that is the impact that you have on one person in this world, and then multiply it by 10 years, 6 patients a day, working 3 days a week, 365 days a year, and come up with that number of how many people you've affected, and then multiply it by the number of family members that they have that now get to have more time with them as a result, and how that's impacted them. And very quickly you will find that the world around you is different because of you and because of your choices. So take that serious, because this is what you were about to walk into, and this is the journey you're about to walk on. I hope you understand that. Next slide. All right, so the head is composed of, well, the head and the neck have multiple structures. We have the top part of the spine, which is the cervical spine. We have, you also have the C1 atlas, C2 axis, because each vertebrae are numbered. You have the esophagus, the trachea, 2 different spots, 2 different pieces and parts, but they're very interconnected, because when we talk about the esophagus and the trachea, a lot of the time we are referring to a little flap that is within the esophagus called an epiglottis, and its purpose is to shut that valve, so when you swallow food, it doesn't go into your windpipe, right? So it doesn't go through our bronchial area, and it shuts it flat. And then when you're done swallowing whatever you're swallowing, then it opens back up so that you can breathe. So this is going to be something that we talk about often related to GI issues. A thyroid gland, this is going to be endocrine, which is going to be a big deal. It's that little butterfly bit that you have on your neck, a little bit below the area of your vocal cord. Let's see, arteries, veins, of course, lymph nodes. That's important because when we deal with patients that have things like lymphadenopathy, we have to treat them a little bit different because their lymphatic system is disrupted. All right, so all big pieces and parts, but all within the same structure. So next slide. All right, so the head, we're going to talk about the skull. Skull has a lot of pieces and parts. They all work interdependently, but are definitely necessary for other things to process along the way. You have 6 bones at your sutures. The sutures are a funny word for pieces and parts of your scalp that fuse together as you age. As an infant, obviously, these are separated, which is why you can see the thump at the top of the head. That's one of those areas. I'm not going to get into those because I don't want to confuse too much, too quick, too soon. All right. So we'll talk about those later. You'll learn those later on in other classes as well. But basically, we have 6 bones fused at the suture. Of course, we have the scalp. We have different layers that we're going to get into of the skull. I don't know if it's this lecture, but I kind of feel like it's either this one or it's neuro, where I get into the different layers of tissues, but we won't worry about it right this second. Mandible works with your temporal bone to form what they call the TMJ, or the temporomandibular joint. Also super important in our ability to eat well, speak well, and without having any major dysfunctions. So we'll go to the next slide. All right, let me get my pointer out because there's a couple of pieces and parts that we're going to see often that we need to know for sure. So first off, frontal bone, definitely need to know that. This one comes back a lot, especially when we talk about mental health, when we talk about personality disorders. This area of the brain is very important, and this area of the skull is very important because we want to protect this area, because this area dictates our understanding of thoughts and processes, our personality, our adaptability, which is very important, our resilience, things of that nature. So incredibly important to know the frontal bone, the parietal bone as well. So this would be articulating the left side of the body because I'm looking at them. Right now, it's hard to decipher your left and your right because we have to talk about it in 2 ways. I talk about my left and my right, and then I talk about your left and your right. So it gets really confusing. And I remember as a nurse, I had a really hard time as a nursing student telling my lefts and my rights the right way. So here's what I ended up doing. I ended up doing what nurses do best. I ended up not making it about me. So what I did is I made myself for 1 solid week, 7 days, I made myself talk in other person's perspective. So I wouldn't, if someone say, hey, how are you doing? I wouldn't go, oh, I'm doing fine. This has been going on. I would look at them and I go, well, I don't know. How are you doing? I understand that, you had some surgery on your eyes. How are they feeling? How is your left eye? And point to it, right? That way you're articulating their left versus their right. So you get used to it. All right. So that might help you. I don't know. Maybe it's just one of those, crazy ASD things. Who knows? I have no idea. But for me, it worked because I always like to find an association for everything, because if you have an association between remote memory and cognitive process, as well as tactile memory, then that's in somatic memory. You're putting yourself in a better position to retain that information. Okay, so that was what I would do. So the parietal bone is very important because it protects the parietal area of the brain. And when we're talking about the left parietal or the left tempoparietal, these are the areas that are super important with our ability to speak and understand speech, which is why if we have a stroke like right about here, or if I'm going back a little bit, right about here, this is Broca's motor aphasia and Wernicke's speech reception. So it's your ability to speak appropriately and to articulate that speech. And Wernicke's, our little buddy back here, Wernicke's is our ability to understand speech. So if we have an infarct in these areas, specifically in Broca's, I have broken speech. That was my association, to remember that. So if I'm dealing with Broca's, I could also have a swallowing problem. Hold on, wait. What else could I have a problem with if I have a problem swallowing? Well, I might even have problems swallowing my own saliva. So this is where this part of the brain is very important for you to remember. If you remember any of these terms, these are the ones I want you to remember. She's sad that you're not thinking of any other bones, but I'm not finished, so I'll get there, Athena. She also wanted me to tell you about the maxillary bone and the lacrimal and why these are important. So maxillary bone is important for your maxillary sinuses. Super important. And then your lacrimal bone is important because your lacrimal duct allows you to cry and to tear up and to get, adjutants out of your eyes. So it's very important that you remember these bones if you're going to remember any of these bones. Athena, you make it so hard. And I did so good on this slide. Just let me keep it, honey bunny. All right. So that's all I have for this one. Let's move to the next one. All right, when we talk about extraocular structures, there are some pieces and parts we're always going to come around and see again. So conjunctiva is going to be one of them. Lacrimal glands, like I told you. See, I told you it's going to come back. It's already happening. So those are words that you're going to see often where we're talking about assessment, things of that nature. Palpebral fissure. It's the opening in between the eyelids. Is it something that I would commit to memory versus something more important? Know it for the sake of knowing it. Know that you're probably going to have to give it a Google later on in life when you've been a nurse for a few years and someone mentions it. This doesn't go in the permanent display. This is what I would like to call a sideshow exhibit at a museum, but it only is around for a little bit. So know it for the sake of knowing it. If you forget it, it's not the end of the world. If you forget conjunctiva, it might be a problem. And the same for lacrimal gland because it will come around that often. So yeah, these are the two membranes and sacs. You can read about those. When we talk about eyes, we always talk about the big four. The big four is macular degeneration, which is a type of visual disturbance, and we'll probably be getting into that very shortly. We will talk about diabetic retinopathy. That's always one that comes back up. And there's a specific way where you can actually look inside of the eyeball using a specific scope, and you can actually see the diabetic retinopathy within the back of the eye, which is kind of wicked. You usually also have a big glaucoma area, so you go over glaucoma for a hot minute. And glaucoma usually comes back when you have an exam specific to eyes. So if you ever have an exam that includes the body system, we're always going to mention glaucoma. There's opened and closed angle, and I'll get into those because I'm sure we're going to go over that because we're going over eyes right now. So I'll explain those pieces and parts as well. Next slide. All right, so if you guys were paying attention, you would have been like, wait, she only mentioned 3. Wait, she's doing that scatterbrain thing again where she really doesn't know what she's doing. So she's trying to recover over here. Actually, no, I did this on purpose. Most of the things that I do, you think I'm being scatterbrain, but I'm actually acting scatterbrain for a reason because I'm teaching you a very valuable lesson about something specific to just you, because that's how I do holistic teaching and training. Is I basically make myself like a clown, right? Like I'm a giant clown to everybody, right? And I do that, and I look scatterbrained, and I look silly, and I look like I'm unkempt, and I look like I'm, wavering. I do that because I want you to understand that I too am human, right? And whatever preconceived notions you have of me, because of the way I carry myself, because of the way I articulate my speech, because of the fact that I'm monotone and I'm nerdy, and everyone kind of looks at me as this person that kind of knows every answer to every answer, which I think is fantastic, but is not realistic at all because I'm just a person, right? This is what I do to help you identify the fact that I am just like you, right? This is the way that I bond with you. Because I don't care what you guys think of me. What I care is what you think about yourselves and how you perceive yourselves. So I don't care to look like a clown if it means that you understand the kings and queens that you are. It's that simple. So my 4th principle is retinal detachment. And I figured, hey, this is a great slide because I can see the next slide that's about to be presented. So our next one's going to be brain, which is also nice. But retinal detachment is going to be your 4th point of contingency that's always going to show up on your exam. So retinal detachment is a medical emergency. We are probably going to be talking about it here in a minute, I'm sure. It's a medical emergency. It is marked by seeing flashes of like lightning bolts, followed by you've only got a couple hours to get in and to get it grafted back and put back in place, or you could lose your vision permanently. So super huge deal. And I thought that since we were looking at this beautiful area right here, we can see where clearly that would take place. So we'll talk about the retina. We'll talk about the retinal arteries, its pieces and parts. We'll talk about retinal detachment, why that's such a big deal, and I'll get into a little bit more information, and I'll start talking about the procedure that goes along with that, so that, again, you can have the enhanced learning experience, but you're not cramming for this, because this is just icing on the cake. This is sitting down with me and having a conversation and understanding all of the things that you've been quickly taught thus far, as well as things you're going to be expecting very soon, so that you can prepare yourself for the next set of classes that you're going to have. Cool? So next slide. All right, so I'm trying to bring your left side of your brain and your right side of your brain. I'm trying to let them hang out with each other for a little bit, because a lot of people either think predominantly on one side or predominantly on the other. And even though it doesn't quite work that way, for the sake of you guys understanding the brain and understanding all of the things you probably heard about the brain that are... I know, they're completely false, but they don't know that yet, so calm down. But it's okay, I'm about to tell them. It's okay, I'm about to tell them. But it's fine. I'm about to tell them right now. So, for the pieces and parts and understanding how this is working, the person is laying down flat right now in this imaging. So they're laying down flat, and this is the top of their head, basically. And then as they're laying up, their nose is here, their ears are here, and they're laying straight down the tube this way. So feet are at this end, far end, poking up right here would be where they are. So I hope that helps. And that's why we have the left eye here, the right eye here. A lot of people will look at this picture, and because they're so used to seeing the left eye here and the right eye here, when we're seeing a face, they get mixed up, and it's easy to do. So again, let's go back. I see frontal lobe again. I see temporal lobe. So like I said, these come back over and over. I see occipital lobe. All right. They will always come back, and they are all intercorrelated with many disease processes. For instance, we talked about the retinal detachment, but we also need to worry about the occipital area and the optic nerve in that area as well, because if you crack your head from the back, you could lose your vision temporarily. You can mess up those areas of the brain. So if you get hit in the back of the head, that's your vision, buddy. So that's kind of how that works. See how far back all of this is right here, the visual cortex? Boom, right in the back. So keep those things in mind while we're doing this. Just because I'm talking about eyes doesn't mean every condition is going to be related to the eyes. Some of it might be related to the head, or related to traumatic event, etc., etc. Yes, we're going to take off in 3, 2, 1. Athena says next slide. All right, here we go again. Lacrimal glands. They form tears, combined with sebaceous secretions to maintain constant film over the cornea. So what would happen if we didn't tear up well enough? Well, they would dry out, and then things would go very bad very, very quickly, right? Very simple. So this is, again, a reoccurring thing that you are going to see over and over. So I would definitely pay attention to the lacrimal gland. Next slide. All right, so ocular structures. Your sclera is your outermost layer. Athena has decided that every slide she's going to make some sort of sound, because I have tried to get her to calm down 3 times, and she's not, so I'm sorry. So sclera is the outer layer of the eyeball. It's the white part. The uvea is the middle layer, and then the inside of that, or the inner layer, is the retina. All right, so that's how we break those pieces and parts apart again. So if you need to reference that, it's slide 7, where I have the picture of the eyeball. So next slide. And again, the sclera, it's the fibrous layer, or the white part of the eye. This is the part that we check when we're checking for things like jaundice. All right, so eyes are always going to come back, because we could have a blood spurt in the eye because we had a vessel break. We could have a lot of impact injuries will result in blood in the eyes. Sometimes a hemorrhage, a subarachnoid hemorrhage, will also include blood spurts in the eye. There are diseases where you have a blue tinge in the eye. So the eyes come back quite a bit. Again, sclera is the tough fibrous layer of the white of the eye. The limbus, I'm not going to freak you guys out about that. I'm going to let you read it. I'm going to let you take it for what you want to take it for and then move on. How about that? And then we have the cornea, and that covers the iris, which is the color of the eye, and the pupil, which is the dark part. It's transparent. It doesn't have any vasculature, all right? And it's innervated with sensory nerves. Now, why is that important? Well, it lets us know when we need to accommodate, right? Because it's another way of sensing how we're going to have that visual acuity. So, yeah, I think that's about all I've got for this slide. Yeah, let's move to the next one. All right, here's where these slides get hairy, and let me just go ahead and preface this with a couple of words. If you don't know this stuff, it is not going to keep you from being a bad or good nurse. The only thing that it's going to do is maybe you might not connect the dots with a couple of things related to the eyes, and it's going to be a far reach of an instance where you're ever going to run into needing that information. So most of this is what you learned in anatomy, all right? You have the choroid layer. You supply blood to the retina with that. We talked about the iris. And then we have some cranial nerve innervation. I'm going to do a separate lecture on cranial nerves. I'm not going to do it in the next couple of weeks. I'm going to do it towards the last few weeks before we go to do our head-to-toe assessment. And I'm doing that because I want you to focus on the brain system last, because we are going to include the cranial nerves, and I want to give you guys a solid 2 weeks to get that down, right? Because I do not want that to be a big deal to you. So that's why I'm just barely introducing them at this point. All right. Ciliary bodies, again, we adjust lens to accommodate. So those are those pieces and parts. Next slide. All right, so the retina is the inner layer, an extension of the nervous system. Two big pieces you need to know about here, rods and cones. So here it says rods and cones perceive images and colors in response to varying light stimuli, and that sentence implies that both rods and cones perceive images and colors, and that is not the case. I'm here to tell you it is not. I repeat, not the case. Here is what you need to know. Cones perceive colors, okay? Rods enhance images by way of responding to lower levels of light. And here's how we know this, because when you're in low light, do you see in color? No, you see on go grayscale, because rods ain't got nothing to do with color, okay? So here's how I remember this. I remember cones provide color, and rods help me get some rays. I'm making a sun. This is my proverbial sky right here. Anyways, so yeah, I remember rods help me get some extra rays, because rods respond to low levels of light and try to accommodate so that you can see. All right. Case in point, it is 4 a.m. and you're trying to go find the bathroom light because you have to go to the bathroom, or because you woke up and you were hungry, like mad starving. So you have to go find the bathroom light, and that couple of steps walk is a little dicey, right? And all of a sudden we start to get a little bit of accommodation, so we can at least see shadows of things. Now, is any of that color at any point? No. Remember, rods enhance the rays so that I can see really well in low light. Cones enhance the color and responds to higher levels of light. All right, next slide. All right, so basically the optic disc, it's the round spot in the retina that's formed by the passage of the axons of the retinal ganglion cells, which transfer the signals from photoreceptors of the eye directly to the optic nerve, and that's the reason that we can see. Now, if you guys have no idea what any of that means, because those are big fat words said very, very fast, because I'm a big fat nerd that's been reading this for 12 years and you haven't, here's how this works. They are the battery, and that charge the battery gives a light switch, or a flashlight, sorry, when you click it on. that's what that is. That's all the slide says, is it basically sends the signal to my brain that says, hey, guess what, you can see. Or down to the optic nerve, I'm sorry, not the brain, because the brain's the one talking. So it's the one that says, hey, guess what, all of a sudden you can see. And then the eyes go, oh, okay, cool. Yeah, oh yeah, that's definitely a kid right there making all that noise. Yep, perfect, done. That's all that this says. And we do that by way of cranial nerve 2, which I'm not going to make you freak out about knowing that. But if the name is optic for cranial nerve 2, olfactory, optic, ocular, motor, remember? If it's optic, then of course it's going to be the head of the optic nerve. So there's that. Done. All right. Also, no rods or cones in this area, because this is all about neurotransmission, right? And this is all about receptors sending transmissions. So we usually leave those little fun areas that have accommodation and also have color, right? We keep that area away from it so that we can get a nice signal sent over and nothing gets in the way of that, if that makes any sense. So yeah, that's kind of how that works. If it confused you and it doesn't make any sense, don't worry about it. It's in a million years as you being a nurse, unless you're just going to be an eye nurse, which I'm not even sure that's a thing. It might be in primary care land, I'm sure, somewhere. It's going to be okay. If you miss any of this, it's not the end of the world, so it's okay. I'm just trying to teach you some things, and I'm just hoping some of it sticks. That's all we're doing here. So next slide. So rods and cones, they're big buddies of one another. They're the Bert and the Ernie of the eye. They're just always going to be together forever, right? They live and die together as old people, the rods and the cones. So rods and cones, again, rods responds to rays, or it helps us with low light. Cones color, all right? And they respond to light stimuli in variable ways, right? Because obviously your color, if it's darker, it's going to be a darker color than if it's sun shiny outside. So you see how they have to work interdependently. Your lenses are constantly going to adjust to stimuli around you. For instance, I could be accommodated watching the TV right now, and a gnat that came in from outside can go. And where do gnats always like to jump? They always like to jump in your eye, right? It's crazy. So that trigger of that fly or that gnat coming by my eyeball to see if it's cool to dive in there, because that's what they do. I don't understand why they do. Why do they do that? Somebody Google that and let me know, right? And when you do, I'll be so excited about it, because I just don't have the time to look it up right now. So yes, they'll go by, and then all of a sudden we're constantly adjusting to that accommodation, because we want to close our eye as fast as we can before that bad boy gets in there, and it's gross and it happens and it's yucky, right? Like that's what that's about. Okay. And the lens focuses on those nerve impulses, i.e. I see out of the corner of my eye something flying in my direction. Oh, it's getting awful close. Sympathetic nervous system trigger. Ew, gross. It's going to get in my eye. Shut the eye. That's kind of how the brain speaks. That's the language that the brain speaks. That's the thought process that the brain goes through. I kind of look at the brain, in my head at least, like that one movie from Disney. It was Pixar. It had the joy girl in it and the anger guy. I want to say, what was it? Oh gosh, gross. No, I'm like that green girl. Oh, that wonderful, wonderful movie. It was the perfect depiction. Inside Out. Inside Out was the name of it. I hope that I was right. I'm going to check it later. I think it was Inside Out, right? So this is how I look at the brain. They all talk to each other kind of like that. And if you can create that cartoon in your head of how the brain's acting, it becomes these pieces and parts that we talk about, these body systems, they become part of the human experience that the human is having as they walk through life, right? Think about it. All of this is going on in their head. It's kind of like a comedy. It's kind of like watching a person unfold right in front of you. And it's quite an amazing thing to see it from that angle and to realize just how precious life is, right? And to laugh at the little nuances that our brain and body does and how it responds to simple, stupid, silly things. At least that's how I see it. So I hope I didn't annoy you with all of that. But I want you to find joy in doing this, because there is joy in learning about these body systems, because you learn so much about yourself and your friends and your family, and you start questioning the meaning of life, and then you start, questioning your own understanding of yourself, and it's a beautiful thing. Nursing school, it's a transformation. It's a journey. It's not just a program, right? It's a program. It's a lifestyle. You've chose the one profession where this becomes a lifestyle that never ends. It's 24 hours, 7 days a week. And you will do it and not even realize that you're doing it, and you don't even care. That's the great thing, is I have the job where no matter how angry I get at what's happening around me, I am never for 1 second going to trade this for anything in the world. And I know that because there's just something about being able to do this for you guys, because I know the pain that I felt when I was in school, and I know the self-doubt and self-loathing and all of the things that I did, and I know the journey I had to go through, and I didn't have a buddy or a guide or a friend or a resource or somebody that knew what it felt like to be this person, this student in this crazy medical realm where nobody understands what I'm like. Friends, it's funny to me because as nursing students, you finally, for the first time in your life, if you aren't, clinically diagnosed with autism spectrum, you actually get a solid 2 years of what it's like to be on the autistic spectrum. Because quite honestly, you live in a world where you're around a bunch of people who don't understand where you're coming from, and you don't know how to articulate that you don't understand, because in your brain, they're so astute and above you because they're your professors, so you don't want to ask them questions and look stupid, and you don't want to look stupid around your peers, so you don't say anything there. Oh honey, this is every day at high school for me. Okay, welcome to the world of this is what Asperger's feels like from the inside. Okay, so this is a journey that I like to even watch you guys go through, because I get to see you be the old Molly. And then when I get to see you graduate, I see you start to turn into a piece of fire. And then you get to be a little bit of the new Molly and transition into your own self. And that's so cool to me. Like, how could I possibly get angry with that? You can't. It's just amazing. So yeah, there's that. There's ocular function and a couple of other rando things that I threw in there. And let's go to next slide and make it a little bit shorter. All right, so ears. Ears, super important for a couple of reasons. A, to hear. B, maintaining equilibrium. Ooh, this is a big one. Ooh, this is a huge one. All right, so maintaining equilibrium is so serious. It is so serious, in fact, that your whole entire day is going to be disrupted if you have a problem with even a small change in your equilibrium. Okay? So we've got the external ear, the outside, the middle, and the inner, which is the part that we don't want to poke, which is why we never use Q-tips. That was my Q-tip platform, so I'm going to jump on that. Don't stick a Q-tip in your ear. That's not what they were made for. Also, no keys, no long nails, no literal nails, because I've seen a 16 penny in someone's ear get perforated. Yes, I cannot make these things up, and it was disgusting, and it was awful, and it was a rusty nail too, might I add. Yeah, go ahead, make all the sounds you're making right now. I know, because I can hear it in my head, because I want to scream just like you're screaming right now. So that's the inner ear. And within that are bits and bones, and a lot of those are important, specific to your ability to stand up, to hear, to appropriately feel the vibrations of somebody else's tone so that you can articulate what it is that they're saying, so it doesn't sound like a bunch of mumbling, right? Those type of deals. Cranial nerve 8 is called the acoustic nerve, I've heard, but I know it as vestibular cochlear. Most neurologists are going to call it vestibular cochlear. I've never heard one neurologist in my life say acoustic. Never. They would look at you like you had 4 brains. So no. But for the purposes of this, vestibular cochlear, think of it this way. If I draw a face and I draw an ear, if I draw the number 8 next to a circle, put 2 dots in for eyes, a nose, and a mouth, and those 8s look like ears. So cranial nerve 8, vestibular cochlear. Done. Next slide. Okay, so let's go over this very quickly, and then I'm going to show you a picture of the ear. External ear, there are lots of pieces. There's the auricle, there's the pinna. You're going to know about the pinna and the auricle. That comes around a lot, specifically the pinna. This is where if you are listening to, or if you're trying to examine somebody's ear, how would you pull back the pinna, right? And how you would pull back the pinna is based off of their age. So if they are 3 years or younger, you would pull the pinna down. If they're 3 years or 4 years or older, you would pull the pinna up, okay? Because 3 is a lower number, you pull down. 4 is a higher number, you pull up. Done. That's how that works. That's a classic question that you're going to get on your standardized testing, your NCLEX, your exit HESI. I see it nearly 100% of the time, every daggone semester in some derivative, right? But it's about a kid or it's about an adult, and you're doing an ear examination because either their ear hurts or they, went swimming, or some rando scenario that doesn't even matter. They're just trying to change the question up, but they're still asking for the same answer. Oh, there's a pattern to these exams, by the way. I'll teach you about that later. So, yeah, that's kind of how that works. But the gist of it is they want you to recognize how you pull the pinna back. So they'll let you know how old the patient is. And again, if it's 3 or under, you pull down. If it's 4 or above, you pull up and back. Okay? So next slide. All right. So the auricle. The auricle is this bit of the ear. Okay? They also call it the pinna. But when you're making the movie The Matrix, it's far cooler to call the person that hears all and sees all the auricle rather than the pinna. Oh, you guys didn't know that's what that was about? Yeah, it is. I know it's O-R-A-C-L-E, but the word O-R-A-C-L-E comes from the actual auricle. So it's the idea of knowing all and seeing all, the idea of being one with the world around you and being all-knowing. Was based off of the idea of hearing and understanding the vibrations, and then taking that within your spirit, right? So they would call, the deity or someone who's hierarchical as, the oracle for that reason. So now you're not going to forget about the ear being called the pinna or the auricle. There's that. Usually we mention tragus every now and again. It's right here. People put piercings here sometimes. None of this other stuff you're ever going to see. This is lobule. And I don't really see a lot of the rest of this. External auditory medius is, of course, this bit of the ear, right? That's going to be in there a lot because this is going to be how you interpret whether there's an inner ear or an outer ear issue, and I'll explain that if we get into those bits and bobs on later slides. So let's look at another image and diagram, and I'll show you some other bits and bones. All right, this is the part where I introduce you to the malleus, the incus, and the stapes. So the malleus is known as the hammer. It's attached to the eardrum, so that's one of the 3 bones in the ear. The 3 bones in the ear are very important because they conduct physical and auditory waves from the outer ear into the inner ear. So if these get messed up, we got a big problem because the waves, plus the frequency, plus the energy with which you push those words, which is why we call it spelling. Because we push the energy of a word or phrase using influx of our frequency, vibration, and energy, and we push it out into manifestation, push it out into the world. This is why when we hear about people who say that they think they're going to have cancer, they get cancer, lo and behold. I wonder why. That's interesting. We've done plenty of cross-reference studies and meta-analysis on this. So if you get bored one day, you can look it up and really, really, really blow your brain wide open at how ridiculous life really is, because you'll find that you truly co-create your own existence. Just letting you know. So, 3 tiny bones. The hammer, the anvil, and the stirrup, or the malleus, the incus, and the stapes, depending on how you want to look at it. So the hammer or the malleus attaches to the eardrum. The anvil or the incus is the middle of the chain of the bones. The stirrup or the stapes, those are attached to like a membrane covered opening. It connects the middle ear with the inner ear and kind of like a oval formation, like a window. All right. Those are incredibly important pieces and parts that you're going to run into. Eustachian tubes are also very important. You'll hear eustachian tube quite a bit. Again, cranial nerve 8, vestibular cochlear branch. Let's see where it goes into. The facial nerve. The facial nerve. All right. Do you see how important these all are? Right? Which is why when you get all of this backed up, one of the things you have, if you get a bunch of fluid in the ear, you're going to get a banging earache a lot of times. You're not going to be able to hear very well because, again, when you put vibration through water, what happens? The ripples don't become like this. They become wider. And as they widen, that wavelength and that sound and perception of that sound degradates. We like this business. The ones that are really close in, those are the really nice sounds. The ones that are, right, they get a little bit harder to interpret as they get longer in the chain, if that makes sense. It's like the auditory winky bach, if you will. So if you get water stuck in this is a big problem. So you got pain, you got water. You might have a little bit of drainage depending on if there's any infection in there. But your face hurts. Your teeth hurt. You're dizzy. You guys have never had that? Surely you've had that. Surely you've known somebody that has it. It feels like your whole face has been like hit with an ice pick. It's awful. You hear your heartbeat in your ear. It sounds like soldiers stomping. I've had ear problems most of my existence. I have Meniere's disease, right? Like it's a thing. But it's not it's unavoidable. It's genetic. My dad had it. So it's always been a problem for me. So you hear me talk about my ears a lot. And twice a year I go deaf for a month. And I'll talk to you about that too if we get into it, because Meniere's disease is another one of those hotspots we talk about when we talk about ears. We'll always talk about ear infections. We'll always talk about swimmer's ear. We'll always talk about Meniere's disease. And we'll talk about dietary changes to Meniere's disease. That's always a question. Things of that nature. And your bigger examinations. Now, for the purposes of what we're doing in this class, I want you to focus on your comprehensive overview. Again, this is just a extension of your learning experience so that you can learn a little bit more about what it is you're going to be doing. Next slide. So here I am talking about this, and it's the next slide. So I'm going to go ahead and let you just get out of this slide and go to the next one. Done. All right, so we didn't talk about the middle ear and the eustachian tube. We mentioned how it's important, but not why. So this opens when we yawn, when we sneeze, when we, do things during a pause, in order to regulate the pressure so that you don't have pain. And you'll know this because if you've ever sneezed and held in your sneeze when you had a really bad sinus infection, you felt like the front of your head had just been stabbed with a knife, right? I know you guys have felt that pain before. If I felt that pain, you guys have felt that pain, all right? That's what this does. It prevents that from happening. And what happened was there was too much accumulation and pressure in that area, and it hit that threshold for pain to go, ouch, so that you don't do that action anymore, because that's your body's way of saying, hey, stupid, stop doing that. Hey, dummy, stop doing that. The body has a lot of mechanisms that says, hey, dummy, stop doing that. Right? So I want you to look at that kind of in that type of framework. All right. So it's also important because of sound waves. And again, this is about vibration. This is about how it vibrates into our inner ear and that pathway that it has to take. Because if there's any disruption, we lose service. Uh-oh. That's what I just said. Uh-oh. I can't hear nothing. What'd you say? Uh-oh. Thank you. That was perfect timing, child. Just perfect. That was really good. I couldn't have scripted that better. All right, next slide. All right. If you recall back on slide 19, we were looking at the structure of the ears, the cochlea. Cochlea coiled in snailed shape contains chordate structures responsible for hearing. Just know that the cochlea is important. Know that the vestibule is important because it has to deal with the balance and equilibrium, the vestibule. And know that the cochlea is in charge for hearing. Vestibular, balance, cochlear, hearing. Done. And then let's just leave it at that. There's a lot in between. It doesn't matter right now. It doesn't matter for the purposes of this entire degree program. So next slide. All right, when sound waves reach the cochlea, they cause those hair cells to start moving. And those hair cells are sensory cells and receptor cells that branches off into the acoustic nerve. Again, acoustic is not something I'm used to calling it. It's the vestibular cochlear nerve, cranial nerve 8, whatever. Looks like an ear because the number 8 next to a circle and a face looks like vestibular cochlear. You're really not going to forget this one. I've said it so many times at this point, it's annoyed you. And that's exactly what I'm trying to accomplish right now. So I think I've succeeded. Number 8, vestibular cochlear. It's always the hardest one for everyone to remember, but it's the easiest one because it's the one that comes up the most. So you'll find that out as you move along your program. Yeah, I've said everything I need to say about this. So next slide. All right, so let's talk about the nose. All right, so the nose humidifies, filters, warms, keeps pathogens out, keeps pollutants out, things of that nature, conserves heat and moisture, right? Helps you breathe, identifies odors, resonance to laryngeal sounds. Yeah, for sure, which is why when we get sick, we sound like this because of that laryngeal passage. All right, so that's why we get nasally. So yeah, let's talk about that. Next slide. All right, so this is a sagittal cut. This was my first day of human anatomy and physiology that I had. It wasn't the slide, it was an actual human, I'll never forget, who had been cut just like this. And our job was to put stick pins in each of these places, just by recollection. And I remember going, I didn't read the chapter, and we haven't had our class yet because our lab is on Tuesday, but our class is on Friday. I'm so confused how I'm supposed to know this. And my professor was very, very upset. And towards the end of the class, I was the only one who was willing to speak up. And I said, you know, our class isn't until Friday, right? Were we supposed to read a chapter of 161 pages before we even had class? Because it's the first day of class. Like, of all the classes, I'm confused. Should I have started studying when I got the syllabus? Because I thought that you were supposed to teach me. And he kind of felt like a ninny and ended up being one of my favorite teachers in the whole wide world. So we got a little bit of grace for the rest of that evening because, again, I talked to somebody like a human being and not like somebody who I would be afraid to talk to because of their stature, because stature isn't really a thing. It's a box we put people in. Okay. You're not better than anybody. None of us are. We all are very good at some things and all very terrible at others, right? I can definitely attest. So, boxing people in and creating, this weird unknown territory of speech, right? Where it's just uneasy. We don't want those kind of things, especially not in medicine when we don't have time for all of that. I don't have time to play games. I don't have time to spread gossip. I don't care about it. I'm here to impact lives and save people, right? So, yeah, this was my first day, and we had to pick and pry and all around here, and it was a lot. So here are the pieces you need to know. You need to know the uvula, right? This is that thing that's going to trip your reflex, your gag reflex. Your tonsils. Tonsils are important because when we talk about tonsillar issues, the stage of the tonsils coming together and touching is going to be determinant on whether we're going to do immediate intervention or whether we're going to just use medication management or if we're going to do something else. So that's always going to come back. Sphenoid sinuses is one of your sinus cavities that you have. Ethmoid is the one that's closest to it. This little guy right here. That's the plate of the ethmoid. So when you have a bad day at work and you go and you rub the sides of your head, that's your sphenoid that you're rubbing. That's why. Because this relieves a whole bunch of pressure. Of course, you got your frontal And then if your nose was put together, this would be your cheek right here, and this would be your maxillary, and it kind of goes and swoops like this, and it kind of goes around and up as well on either side, and that would be if the nose were put together, and this would be a 3D interpretation, and the face would be attached. That would be nice. The turbinates, you're not going to really be messing with those a lot, although I did talk about those in an earlier lecture. The vestibule, like we talked about. There are 2 pieces of cartilage right here, and then of course we have our bone. There is oddly specific type of septal cartilage right here, and then of course the upper third is nothing but bone. Lower 2/3, there's a hard palate in there. Let's see what else. I think that's about all I got for this one. So let's look at the next slide and see what we're doing and where we're at. All right, always a good indicator if I basically speak over the entire slide. So there you go. Yep, I think I covered that too. Cool. Oh, also the cilia. This is important. Your nasal cavity has highly vascular ciliated mucous membranes, and the cilia, they grab the junk before it gets to the lungs, and the hairs as well. Like that's the whole, that's what we talk about when we talk about the cilia. All right, next slide. All right, cool. I saved us some time because I talked about all these pieces and parts and what they do. Yeah, I got everything. Yep, next slide. So yeah, I think I got all this too, the paranasal sinuses. We talked about all those. Again, the cilia are those vibrational hairs that feel the lightest of the lightest touch, to the point to where we would want to sneeze out particles, because those cilia have been triggered to send a signal to you that says, hey, your nose itches because something's in there. So that type of a deal. Everything else I think I covered. So next slide. Hey, this is what I was hoping for earlier. So yeah, we've got your ethmoid, your sphenoid, your maxillary. Like I said, it swoops like this. We've got, yep, that's everything. Every little piece and part. All right, next slide. All right, so our mouth. We have lips, tongue, teeth, gums, salivary glands. The hard palate is at the roof. Soft palate is in the back, which is why you can stick your tongue to the top of your mouth and it's hard. And as you go back, it gets a little bit softer, like spongy tissue. All right. Tongue has hundreds of papillae, or taste buds. And the dorsal surface, this is important, this always comes back. Dorsal surface has taste buds to distinguish sweet, sour, bitter, and salty taste. Ventral surface is smooth and highly vascular. Boy, is that ever correct, because it's easy to bleed, right? So let's go to the next slide, and I think we're going to see a picture. All right, so let's get to some pieces and parts and see what we got here. So here is the frenulum of your lower lip and the frenulum of your upper lip. So if you know anyone where it stretches beyond that reach and you see a bit of gum, it's because the frenulum isn't shaped like it was supposed to be, right? Some people are tongue-tied, and that would be this little piece right here. Sometimes it is up a little bit farther. But again, we're at the frenulum, so this is the problem. So this is usually how they fix people who are tongue-tied. Let's see, salivary gland for sure. And what else would be important? Again, the uvula. Soft palate is towards the back. Hard palate's right up here. Yep, I think that's all we need for right this second. Yeah, let's go to the next slide. All right, so I'm going to give you guys a little bit of hot information, and I'm just going to trust you're not going to tell a whole bunch of people. So here's the thing. There's 2 sets of teeth. I knew that, right? There are your babies and your permanents. I honestly didn't know how many incisors, premolars, or molars we had because I'm not in dentistry. But there's 32 permanent teeth to include 12 incisors, 8 premolars, and 12 molars. Are you ever in the history of nursing ever going to use that? I mean, maybe if you have someone who had a motor vehicle accident and you have to note which tooth fell out, but I've never even done that. I just said multiple teeth missing and back of mouth, right? Like we've always kept it pretty simple. But I suppose we could get that way if we're talking about that area. Again, in trauma, yeah, again, it'll just say multiple teeth missing in, blank area. We don't talk about what the name of the tooth is. I don't expect you to know these things. Again, we're just enhancing your learning experience. So it is covered with fibrous gum tissue. We know that. Again, rooted in alveolar ridges of maxilla and the mandible. So let's go to the next slide. Again, are you ever going to need to know anything about salivary glands? Probably not, unless there's an abscess. And if there is an abscess that you have to document about, it's not going to be an H&P that you're going to have to do because you're not a physician. And I promise you the physician is probably looking it up if they're internal medicine going, what the heck was that piece part called again? Can I just call it this? No? Okay, fine. I'm just going to give it a Google. This is the reality of what happens behind nursing, because I don't care what doctor you are. I don't care how long you've been a doctor. Not everybody knows everything about everything, right? That's why they call them specialists. That's why we refer them, because there's only so much we see, and it runs in rotation, and mouth and salivary glands usually isn't a piece of it. And like I said, unless this is trauma, but definitely not salivary glands. I've never had a patient with a salivary duct issue ever, because they would go to the dentist. So our biggest issue when we're dealing with the mouth and salivary glands is making sure that we don't have any ulcerations, that we don't have any nodules, that we don't have any issues with ulcerations or lesions, because that is going to prevent a person from eating a lot of times. And if we're dealing with elderly patients specifically, this could be a big problem because, nutrition's everything for that. So let's look at the next slide and see what we got. All right, so oropharynx. We've got pieces and parts. We got the uvula, which we talked about. That's a little punch and bag thingy. We've got the tonsils, which are the things that kiss if you don't watch out, and then we have to take them out of kids. If you ever have an option or an opportunity to get tonsils out as a kid, do it. If you ever have to do it in adulthood, you're going to hate your life, and you're going to hate your mother and father for not taking them out when they could have. Adults, I've seen grown men who are very intelligent, very strong, able-bodied men, ridiculously tough men, break down over tonsils. Down for days, weeks over tonsils. Do it when you're a kid. If you have the option, get it done now. Don't wait, please. We'll talk about why if we get into tonsillitis and what that means in adulthood, because it's far more painful and far more miserable and far higher risk for a lot of reasons. So let's see. Posterior pharyngeal wall, very vascular, very easy to get hemoptysis. Sorry, I said hemataxis. Hemoptysis, which is spitting up blood, blood. All right, so epiglottis. Epiglottis, we are going to have, that's that little flap I was telling you about. We finally got to it. Okay, cool. So this is the little flap that I was talking about that opens and shuts like a gate, and it keeps you from dropping all of the food and fluid that you're consuming into your windpipe. So next slide. All right, so again, when I was in school and I was in anatomy and phys at my university, we had cadavers. We had several of them. We were assigned to 2 of them, and we were in small groups. And I remember I had to learn every single one of these, and they were fairly easy. However, if you notice, there's one word that we're not familiar with. Sternocleidomastoid is probably one that you don't know either. That is what I call the wrestling. There was a wrestler named Goldberg back in the day, and he had the largest sternocleidomastoid muscle I've ever seen in my entire existence. So it's like the muscle within the muscle of the neck. It's like a beefy linebacker's muscle on their neck. It's like 2 extra humps. Give it a Google. It's worth it. And then there's the hyoid bone. And I was thinking to myself, how in the world am I going to remember the hyoid bone? And we also had to learn about the cricoid as well. And for the life of me, I couldn't figure it out. So I'm literally touching the hyoid bone. And when you touch the hyoid bone, it clicks. You can literally click it left and right. And then I figured out how I was going to do this. And I need for you guys to just be super cool with me and not judge, okay? Because how I learned hyoid bone was I would have to be high to sit here and click this bone back and forth because it's right up on my throat. So I would have to be crazy to mess with this. And it looks like we're going to look at a diagram. I don't know if the hyoid bone is on there, but if you ever have an opportunity, of course you have an opportunity, it's your body. If you feel comfortable, touch the top part of your neck, right where your voice box is, and then wiggle left to right, and you'll feel this bone clicking. And that would be your hyoid bone. So there you go. Next slide. So let's talk about some parts here. First off, this right here, this hump, and if I made a hump right here, that would be an extension of large sternocleidomastoid muscles we talked about earlier. It's a muscle right around here. And if we get bulging ones, we look like a pro NFL player. Super important is the internal and external carotid arteries. This is the external. This is the internal. Again, internal and external. This is the only way we supply blood to the face and to the brain. The external supplies blood to the face, and the internal supplies blood to my brain. So if I had a choice between this one getting occluded and this one getting occluded, I would prefer this one to get occluded, because if this one does, I only have a dysfunction of maybe some facial movement. If I do the internal structure, I might have an infarct in my entire head, depending on how severe we're dealing with here, right? Because if I create ischemia in my brain, that is a stroke. Ischemia means lack of oxygen. It means if I put a marble right in here, that means I'm only running off of this guy right here, which means I'm only supplying at half staff. So if this is a literal, let's say that this is a thrombi right there, boom, just like that. I'm only supplying half of my brain, essentially, and that other blood is going to try to pull up and try to save my life as much as it can by rushing blood through. But the external carotid, it can't really do a whole heck of a lot about that because it works a different system. So internal carotids are always super important. And if you always forget what it is, if it's internal or external, which wire to cut, what's the problem, here's the way to remember it. If I go and look back at the creation of the human being, we're probably going to be talking about your creator, whoever that is, if you do have a creator. And most creation stories will talk about how hard that they worked to create human beings. And that is very, very true. Whoever your creator is, it doesn't matter. It's extremely true. They're the best artists of them all are our creators, our deities, whatever that looks like to you, or however you structure that phrasing. So important to this, and the reason I'm picking this apart, is they even thought down to the line of, okay, how hard is it going to be if they get cut or something gets severed? If it's external, I'll go ahead and leave one for the external, but the most important one I'm going to put in the internal structure, because it's harder to penetrate through all of that to get to this guy right here. So this is the structure of your body being built in such a way that it anticipates that you might get perforated with something. You might get stabbed, right? You might get something that will try to endanger your life. You might get cut on the arm with some jagged metal, whatever. So that is why you'll notice all of the most important arteries are internal, the most internal, because these are the ones that are going to create death in your brain. So they're farther in your body, so it's harder to get to it. So that's how great your creator is when they created you. And you're perfectly self, your perfectly wonderfully made self, just like it is right in this moment. So let's see, subclavian we're going to talk about quite a bit, because subclavian, when we talk about PICC lines, this is where it goes. This is where it drops and dumps down. This is one of the ports. So a triple lumen PICC line, a lot of times there's going to be a secondary lumen right here that drops off medication, and then there'll be one right here in this area, so that you can get better medication management, and it dumps right into the right area. So central venous catheters, they will go in these pieces and parts and places. Next slide. And again, here we have our sternocleidomastoid that I was telling you about. These huge muscles right here. And then you got your traps, and then you've got your posterior triangle. None of these things matter. Clavicle, we all know this, your collarbone. Yeah, we'll talk about the next slide. All right, we're going to talk about the neck now. So we have cervical vertebrae. Greatest mobility is going to be in C4 to C5 or C5 to C6. Neck muscles and bones form triangles. We talked about that. We've seen it in the previous slide. We have yet to meet the bones in the back, but you've got your posterior trapezius muscles. You've got your clavicle, and you've got your other pieces and parts that are posterior to that area. And yeah, there's really nothing. I'm like thinking of things that we would normally talk about when referencing this, and we haven't gotten into anything that I think is a hot topic to talk about at this moment. So let's just keep on moving forward. All right, so we're going to talk about the neck and the larynx now. So voice box is just below the pharynx and just above the trachea. All right. So the air that's passing through is what actually creates our frequency of our speech. So if we have a lower voice, if we have a higher pitch voice, things of that nature. And it also helps us from, getting food in there and dying. That's no fun. So again, thyroid cartilage, Adam's apple. It is the largest component of the larynx, and there could be a lot of issues that develop from that, which is why we talk about thyroid studies, things of that nature, as we move on to MedSurg 1 and MedSurg 2. Next slide. So the thyroid is the largest endocrine gland, and it produces two hormones. It produces thyroxine and, oh boy, triiodothyronin. Okay, here's what we're going to have to do, because I know it's T3. I want to just call it T3 and move on, but I can't, because I know if I do that, then somehow I feel like I'm going to be smiting you or slighting you in some way. So I want us all to hear it together, because this one's a big word.
Triiodothyronine, or T3. Triiodothyronine, or T3.
Triiodothyronine. There you go. T3. Just so you know. You'll never hear it again, I swear. Triiodothyronine. Whew, that's a big one. All right, cool. Triiodothyronine. Got it. Okay, cool. And it regulates the metabolism, right? Also the mental and physical growth and development. That's very important, because you'll hear about how we're either very lethargic and depressed, or we're going to be high-wired and very flight of ideas and very space cadet-y and very clouded and irrational in our thinking. So that's super important. Again, we need to examine the area of the trachea to see if we have an enlargement of the thyroid. We'll learn how to do that in lab. Very large thyroids are very obvious. It's hard to feel around a throat because people are sensitive to people messing with their throat, right? Some people are really sensitive for different reasons. So you just got to be really careful. And I always let them know, I'm going to grab you by your throat, but I'm not going to press hard. I'm not going to choke you. I'm just feeling for your thyroid. So I'm going to put my hand on your throat. Are you okay with that? It's kind of how I put that. And everyone's usually pretty cool. There are exceptions, and we talk it out. And I go, okay, fine. Why don't you? I had one person who got really scared during an examination when I was in my residency at, where was I? I was in Mount Vernon. And this was an abuse victim. And what I had to do, because I had to inspect and we had to get it done, and the doctor refused to go in there with me because he was like, nope, this is a perfect opportunity for you to work through this. I had them hold my hand. then I had them slowly move my hand to their throat, and that seemed to work really well. And they did have an enlargement, and they did get a T3 and T4 done and a couple of other studies, and it was confirmed that they did have a problem. So it worked out to my advantage. But it was also a very traumatic moment. And it kind of makes sense too, because going back to it, remember, mental and physical growth are regulated by the cellular metabolism. So it could have been a heightened sensation of that moment, of that trigger, and I am going to use that word because at that point that was an absolutely appropriate word to use. So we had to work through it, and that's how we did it successfully. So next slide. All right, so let's do the neck and some structures. Carotid arteries and the interjugular veins lie deep within the sternocleidomastoid muscle. We saw that earlier from our pictures. Provide important data regarding cardiovascular status. I wonder what that's about. Oh yeah, we're talking about vascular structures, well that makes sense. Carotid pulses palpated along the medial edge of the sternocleidomastoid and the lower third of the neck bilaterally. What in the heck does that mean? Your carotid pulses, they're on your neck. How about that? How about you know where they are because you just saw it a couple of slides ago? How about that? Let's do that. Let's not make it so complicated that I can't even decipher the English, and I've been doing this a hot minute. So, all right, cool. So you know about your carotids. Yeah, let's move to the next slide. All right, so your lymph nodes, they're small lumps of tissue. They contain white blood cells, which fight infection. They're part of your immune system. They filter your lymph fluid, which is fluid and waste products created by the body's tissues. It basically helps to fight infections. It also fills up when there's inflammation and inflammatory processes, so that it can kind of send a signal to your body to say, hey dummy, something's wrong, right? They attack and destroy harmful substances like bacteria. Like they do a lot of things. They do a lot. So when we have a localized or some systemic infection or an abscess formation or a malignancy, the lymph nodes also play a very important role in the defense against those infections, or a defense against that malignancy, which is why you have that ridiculous lymphadenopathy that just is so incredibly large that it looks like a turkey neck. Or a turkey leg is attached to your neck. So it's quite pronounced when it's the bad stuff. So let's go to the next slide. So here is a diagram of all of your lymph nodes. I know in your head-to-toe assessment, all of the lymph nodes were listed and expected to be identified. That is not going to be a thing. That has been changed. I will be giving you more information on that about what our new system looks like on Monday. It's going to be a lot less. We're going to go over it. We're going to go over it in a very easy and understandable way. If we have trouble, we're going to talk about it. So don't worry about it for right this second. Focus on just looking at them and recognizing what they are and which way they would drain, and understand what the role is and move on. All right, here's some more information about lymph nodes. So in the head, it's considered preauricular, postauricular, occipital, parotoid, retropharyngeal, or tonsillar, submandibular, submental, and sublingual. So that's a lot. I would love to get into the Latin and what all of that means, but preauricular, postauricular, I've not used that verbiage in, since anatomy and physiology, if I'm honest, and that was 14 years ago, 15 years ago. So it's not something that we use often enough. Occipital, we do need to know. Parotoid, no, that's not a thing. Tonsillar, sure, we can use that one. Submandibular, sure. It's below because of sub, the mandible, all right? Submental and sublingual. Sublingual, we use medications that way, so sublingual is going to be something we talk about. Submental, not so much, all right? Lymph nodes in the neck are found in chains, absolutely. They are named and according to the relation of the sternocleidomastoid muscle. So again, we keep talking about this muscle. There's a reason that I keep talking about it, right? It's because it's something that we're going to see often. So let's go to the next slide. So this is how we're going to ask questions related to this. We're going to say, have you noticed any changes in your eyes, ears, nose, or mouth? That's going to give us open and relative time for them to think about it, to come back and let me know if there's anything on any of those issues. It shuts it down really fast. It also categorizes them together because we look at all those pieces and parts as one entity, right? Which is, the top part of our body. So it's appropriate to put those together because a lot of these pieces and parts are interconnected. So yeah, do we have glaucoma? Do we have cataracts? Oh, cataracts is another one. That would be number 5. We talk about that quite a bit. Do we have migraines? Do we have hearing loss? Do we have cancer? Do we have hyperthyroidism? That type of a deal. Do we have autoimmune disorders? Things of that nature. All right, next slide. Okay, so medications. We need to know about medications for a lot of reasons. We need to know if we're masking any symptoms. We need to know if we are mixing medications that are going to cause other symptoms or other dysregulation of other body functions. Medications are one of the top questions we're going to ask. If I have a patient who's down and no one knows why he's down, one of the first things I'm going to ask is, what medications are we taking right now, right? Because it's going to explain something, right? It's going to give me something, some kind of indicator of something, right? So it's going to be understood, medications, what, how often, that type of a deal. Those are going to be listed on there for sure, and will always be part of our HMP, or what they call a history and present illness, or present health status. Next slide. Have you had any injury to your eyes, ears, mouth, or neck? I would say, have you had any injury or illness to your eyes, ears, mouth, or neck, and be done. But that makes sense why we would ask those types of questions, because if it's something that I would find and it would be an expected finding, like, okay, David Bowie. So David Bowie had a fight where he was punched in the eye, and because of that, he had a fixed pupil of 5 millimeters on the left side, I believe, and he had a regular pupil that dilated accordingly. On the right side. I think that was right. I think it was his left that was abnormal. So yeah, because of that, he was well known as this, kind of, crazy artist who was fantastic, and he was a great singer, and he was revolutionary, blah, blah, blah. But the reason that this is important is because this was based off of an eye injury. So if I go to see this patient, which would be weird because he's passed now, but if I did go and see him and I saw that he had one fixed pupil on one side and then he had like a plus, like a 3 on the other side, I would freak out because I would think he's got a subarachnoid hemorrhage, and all he's going to do is look at me and go, "You remind me of the Babe." And I'd go, "What Babe?" And then he'd go, "Babe with the power." And I'm like, "What power?" And maybe one of you are laughing because you've seen Labyrinth and you understand that's a movie that David Bowie was in. But I would be really scared of this because I would think that this is a result of a subarachnoid hemorrhage, where this is a regular occurrence for him because of trauma. So this is why we ask separately illness versus injury. I hope that explains things a little bit easier. So let's move to the next slide. All right, so family history is important for a lot of obvious reasons. There are many conditions that are habitual and genetic in propensity. So we need to ask things like, have you had a history of cancer in your family? Okay. What kind of cancer was diagnosed? Are they still alive? Did they pass? Right? We're concerned with certain types of cancers. We're not so concerned with other types of cancers. So like my dad, he had mesothelioma. And he had that because he worked on the railroad and he was around the caboose because he was a simple laborer, and it used to fly all over the place, right? Like we used to fly through it and I used to think it was cotton. So it was like snow. So that's just what you did back in, 1992 or prior to that. And that was the thing. So that's something that isn't genetic. That's something that is a pollutant that causes this type of illness. So that would be different. But it's still important to know, because I would ask, well, have you been exposed to it? Because, when my dad worked for the railroad, I would be with him a lot of times. I would be on site with him. Because, again, 80s children, they are the last feral children of all the children in the world, I swear. Because we were let go to sit on jagged rocks, to play on slides that sliced you open because they were hardcore metal and that were so hot that if you sat on them, you were pretty much going to be guaranteed to get burned, right? And go home with a tan back of your leg if you were wearing shorts. I mean, it was risky living in the 80s. I'm going to be real, because all of our parents were hippies because all of their parents were coming home from a very, very terrible war and conflict. So all they wanted was peace and love, and all they did was show peace and love to everybody else and kind of forget about us. So we had to raise ourselves. So this is why we ask these types of questions, because these types of adults that we have now as patients, they may have had that type of exposure because that was the thing back then, and no one really did anything about it. Not until, EPA got involved quite a bit later, but by that time it was way too late. So let's see. Do you have anything that impacts your hearing, vision, or thyroid? Again, cataracts, glaucoma, sensorineural hearing loss, Meniere's disease, hyperthyroidism. These guys are all notorious for running in a family history. So I'm going to ask, was it your mom or your dad? I'm going to ask, when did it start? Things of that nature, so we can get a better idea if this is going to be a problem for you or if this is potentially a problem you're experiencing and haven't been diagnosed with. So let's look at the next slide. So we ask these types of questions, personal and psychosocial history, for a lot of different reasons. When was your last routine examination? When was your last routine examination actually tells me a couple of things. It tells me how often you're going to the doctor. It tells me if you care about your health care enough to see a professional, to get labs done, to get things done, to let me know that you are as stable can be. And that you take that seriously. So that's going to tell me how you're going to do about compliance, because if you haven't been to a doctor in 25 years and all of a sudden you're here and it's because you had a stroke and I got to teach you about taking your aspirin, you've never taken a pill in your life, and now all of a sudden you've got this thing called a stroke and you've got a little bit of a deficit and you're freaking out about that. And now I'm trying to hammer a bunch of pills in you and you don't believe in doctors. Do you think that you're going to believe in taking your medication? No. So then you're going to come back, and usually you're going to get hit with a harder stroke, and it's going to go really bad, and then I got to worry about getting you an ECF placement. So that's why we ask these types of questions. Yes, whatever you just said. Do you use corrective devices? That's going to be important because we need to know if they can see what we're trying to give them for education. Duh. Lots of doctors drop off lots of pamphlets, lots of cards. If they can't read it, what's the point? Are you having vision disturbances because you haven't had corrective lenses lately? When's the last time you had your eyes checked? How old are those glasses? Things of that nature. Tell me what you do right now to maintain your health. That's also important. Do you smoke or drink alcohol? Also super huge to let me know kind of how well you protect yourself and take care of your body, because that is going to be indicative of how successful I'm going to be as your nurse, who's going to try to educate you through all of this stuff. Next slide. Now, here's a list of common problems related to the eyes, ears, nose, throat, neck. And I'm sure you can just read these and we'll talk about them. I'm sure here in the next couple of slides, it's going to come up. I'm nearly positive. So let's just bump to the next slide. All right, so when we are dealing with problem-based history and headache assessment, we're going to ask them, how long have you been having headaches? This is important for a couple of reasons. One, how often do you have it and how long does it last? What does it feel like? Again, do the onset, do the location, do the duration, do the OCARTs. I want to know these things because this is going to let me know the difference between a cluster headache versus a migraine versus a stroke versus a subarachnoid hemorrhage versus an aneurysm, right? Versus hypertension, depending on how long you've had that headache. If you've had that headache every morning when you wake up for the last, 6 months, it could be sleep apnea, right? It could be a lot of things. It just depends. This is why we play the rule out game by asking all of these questions. So let's go to the next slide. All right, so let's talk about the different types of headaches. So before we talked about, in the last slide, they mentioned cluster headaches versus migraines. Migraines are usually much larger in duration and much shorter in frequency. So I have them very often, and I have them, and they usually last 1 to 3 days. Cluster headaches usually happen in a longer frequency, so maybe up into years. But when I do have it, it lasts hours, and it is the worst pain ever. Now, remember what we talk about acute versus chronic. If this is an acute cluster migraine, if this is an acute cluster headache, then it's going to hurt like the dickens. Think about it. I'm not used to getting it every day. If I have a history of migraines and a migraine comes, I could probably teach an entire class with a migraine. I've done it many a times. And it's blistering, but I'm not going to let you guys know because I'm not going to let anyone know that I've been affected because I'm just used to it. I just keep moving on. It's a dead end scene. There's not a lot that's going to fix it. I'm going to do the things that I can do to help it and let it die down a little bit. But other than that, you're kind of hosed. So when we talk about the location of the pain, certain areas of the location of the pain indicate to us what type of headache it is. So tenderness over the frontal or maxillary sinuses, this is sinus headache. So what do? Well, you dry it out as fast as you can. That's kind of the deal. So for sinus headaches, like a lot of times we say, get you some Afrin because you can't frickin' breathe. And it's causing an accumulation of all of that junk to stay into your sinus cavities. And that's why when I press down, it feels like I'm stabbing you, right? Tension headaches are usually in the front or the back of the head. And migraine or clusters are usually unilateral. Clusters are usually in your eye. Migraines are usually in your eye, but also gives you a vomiting bit that is just to die for. I tell you what, it's just the greatest thing ever to have chronic migraines and to be that person. There's a lot of literature that puts people who are on the spectrum with having cluster migraines, and it's because of the hypersensitivity of the sensory system. So because of the neurosensory overload and because of the receptors being so sensitive to its reception, I guess is the best way to put it. Those signals that they receive them at such a light, such a light touch or a light vibration or a light frequency for us, and we catch on to it so fast that it's a thing. It just goes along with it, right? Because sometimes sounds create a migraine. I don't know, like maybe that one. Man, I tell you what, this kid is on point today. She is on point. She's my Flavor Flav. She's my hype man, right? Like I'm Chuck D and she's Flavor Flav, just walking around with a clock on her neck. God love this baby. All right. So that's cluster headaches and migraines. We're going to talk more about these things, I'm sure. I'm sure in a couple of slides we're going to get a little bit farther into it. And in MedSurg 1 and 2, you're going to get right down to the nitty-gritty of how it all works. But I'm introducing these things to you. All right. So cluster headaches produce pain over the eye, temple, forehead, and cheek. Oh, yeah, for sure. Tension headaches are described as vice-like. So it feels like a rubber band is on your head and you can't get it off. Or maybe 3 or 4 rubber bands, right? It's a throbbing pain. You could feel it pulsating. Clusters create a burning or stabbing pain. Boy, is that ever seriously accurate. It happens behind one eye usually. And again, it's that throbbing pulsation, enough to scare you and think that something serious is going on with you. Next slide. So what factors trigger headaches? Well, easy ones. Stress, fatigue, exercise, food, and alcohol. Done. I would also put in a couple of extra things, but that basically is it. Sometimes inhalants will cause a migraine. Sometimes sinus changes in the weather. So like whenever I fly from Georgia to Ohio, for whatever reason, if it's around August, September timeframe, I will actually drive and not fly, because I have a theory that when you drop from one environment to another with no time in between, it triggers that event, versus if you drive, you're kind of driving through it all, so it's kind of giving you a little extra time to deal with the smells on the ground. Again, that's my theory, and there is some evidence-based practice to substantiate that claim, but we're still kind of trying to figure it out, because again, the brain is like the ocean. We only know about 10% of what we can know. We're trying to figure it out. We're getting really close to figuring out some really huge things. Matter of fact, right now in this time, so it's very exciting, the world of neurology, the things that we're doing. But there's still a lot to have up in the air. Again, migraines are frequently associated with menstrual period because of hormonal changes and neurotransmissions that are changed during that time frame, and about 15 other different reasons that I'm not going to get into right now because it's just going to creep you out and make you wonder if it's on the test, and it's not. None of this is. It's okay. Just learn and enjoy. Enjoy being a nurse. Enjoy learning, because you're never going to stop learning. So next slide. We talked about things about dizziness. So what does dizziness look like to you? Are you spinning? Is the room spinning? There's a difference in the two. One is more vertigo related, and one could be more related to a sinus pressure issue or a number of other things, orthostatic hypotension, yada, yada, yada. Dizziness feels like fainting, right? It does. You may black out. You may see stars. By stars, I mean glitter. Some people call it lightning bolts. I call it glitter. It looks like there's 1,000 little floats of glitter going all around in my eyes. I don't know, whatever you guys call that. And again, it's a sensation of, I feel like, I feel like I'm at the top of a roller coaster and I'm going down, and I'm going down fast. And I can't get my wits about me. That's dizziness. So if you've never experienced that before, which I think we all have at this point, but if you haven't, that's kind of what it feels like. Next slide. All right, so when we ask these questions, we are asking to see what your fall risk is. So does dizziness interfere with your activities? We're trying to see if you're going to have a potential to fall and how often, because I need to figure out if I need to make you a fall risk on my unit. So have you ever fallen as a result of dizziness? What have you done to treat the dizziness? That way it cuts the middleman out, and I know if it doesn't work, I'm not going to introduce it to you because it's a waste of my time, and it's going to make you even worse because then you're going to be hurting for longer, then you aren't going to trust me because you told me and I didn't listen to you. These are the problems that patients and nurses have, and this is why nurses look like bad nurses, because they do dumb nursing things, like not paying attention to what your patient says. By God, they know their body better than you do. You're a better historian as far as medical background is concerned, because you've taught and you've learned and experienced these things through other people and through study groups and whatnot. But other than that, you haven't lived in their shoes. You have no idea what works for them. Listen to them. They're smart. They know their body. And if they know their body and you trust them and they trust you, if you have to tell them to learn to trust you about something, guess what they're going to do? They're not going to think twice, because they're going to know that you got your wits about you and you've got grit. It's the people that give a lot of hem-hawing around and don't really tell them what the other person's experiencing. Those guys make us look bad. You have to communicate with your patient. You have to let them know what your life is like outside of their room. Just like I always communicate with you guys about what I got going on my side. So sometimes you'll hear things uncomfortable. Sometimes you'll go, oh God, I don't want to ask her anything because there's this and that and the other going on with her. No, I'm telling you so that you understand, so that you can then rack and stack and triage the level of emergency that you truly see. Because sometimes an emergency is an emergency until you realize I got an emergency, a true one going on. And then when you find out, you're like, well, maybe I can wait just a couple of minutes and I can calm myself down. And then usually you can. So again, it's all about communication. Everything is about communicating in this world. And communication is a very weird thing because some people really suck at it. I'm one of those people that suck at communication. But I've spent my entire life learning about the human condition and why the brain works the way it does. And if I have those pieces and parts together, then I've solved the puzzle. Right? And the rest of it's just patterns. And I can do that all day long until the cows come home, because that's how I was wired. So this is why I know as much as I know. This is why I study as much as I've studied. This is why I've screwed up as much as I've screwed up, because I'm literally taking it back to you guys, because I've spent my whole life trying to learn how to communicate effectively with the human condition. And I, largely in part, have failed most of my existence up until the last 6 or 7 years. And I'm super glad to be on this side. It's pretty darn cool. I'm trying to get you guys there too. It should be a lot easier for you, so I'm excited. So let's go to the next slide and talk about whatever is on the other side of things. I think we're going to be talking about difficulty with vision. All right, so yeah, difficulty with vision. What type of vision difficulty do you have? Did it start suddenly? Did it start gradually? This is important because this is going to let me know if this is more of a cataract issue or if you literally have had a retinal detachment. That's kind of a big deal, right? I need to find out if, this has been going on since your A1C has been sucky, because that might be diabetic retinopathy just taking its toll. And I can fix that vision disturbance, because if we get your blood sugar in control, your eyes start to get better. It's that type of balance, right? And we'll talk about eyes and what that has to do with diabetes. Again, this is an introduction class, so everything that I'm telling you right now is way accelerated. I'm trying to enhance your understanding of the world around you through the eyes of medicine and what's happening around us. None of this is going to be on your exam. Maybe one or two pieces and parts, but nothing that's going to be so serious that you're going to be mind blown with what you're hearing right now, because it's the first time you probably heard it before. So don't trip. I'm literally just trying to give you a jump start into your experience before you get to these classes and hear all these concepts and start freaking out. You'd already been like, Molly already told me about that. We're good. I know what that is. I'm good. And if you don't, then go back to the slideshow and play it again, because you're going to. And I'm really excited about it, because that means I'm doing something right. So again, this is all about you. That's all I care about. Next slide. All right, again. What makes the vision worse? What makes it better? These are aggravating. These are aggravating factors or relieving factors, right? And that's part of our old cards as well. Has vision problems interfere with your daily life? I mean, we could talk about this until the cows come home. But again, these are the things that we're looking for to give us a quick focus on what is wrong with our patients, so that we can maybe get in line with an idea, so that we can then tell our docs, hey, listen, this is going on. It sounds like it's this. They got all the tall tale signs of it, so they're in room 314. Go have at it, because they appreciate that. They appreciate not having to look and read and have to do more work for a brand new patient. They really rely on their nurse to do those things. It's the equivalent of me being as busy as I am, and then you guys asking me individually if I'm going to be giving you a test on Friday, when all you have to do is just look at the syllabus. It's right there. That would be the equivalent of the amount of work that I would be relieved of if you were able to, ascertain that as a nurse, which you can and you're supposed to. Next slide. All right, hearing loss. How long have you had trouble hearing? What tones are difficult to hear? Remember, when we're dealing with the aging process, higher frequency sounds are going to be harder to hear in aging process. So if you're 80 years old and you say, yeah, I've had difficulty hearing high tones, and it's been going on for the last year. Okay, all of a sudden I'm not so concerned that that's cancer, all right? Because that's a regular finding. That would be an expected finding. So yeah, we're doing things like that so that, again, we can knock this out of the way and go, okay, it's not this. We're going to play the rule out game, kick that out of the way. It might be this, this, or this. All right, do you have this kind of condition? No? All right, well, it's definitely not this, so that leaves two other things. This is how we play medicine. A lot of times, if our patient doesn't know what's going on or can't appropriately convey what it is that they're trying to tell you they're experiencing, if there is a language barrier or just a communication barrier in general. Some people don't know how to tell people what kind of symptoms they have because they're not used to docs. When we run into these types of issues, the rule out game makes things a lot easier to help us fall back in line so that we could, again, properly communicate with our patient. And sometimes in these cases, it feels like we're practicing veterinary medicine because we're looking at the patient. We're looking for, flinches in the eyes to see if they're in pain or increased respirations. That's why we say things like pain is related to an increase in respiration. So check your vital signs. It all balances out in the end because there's always an explanation for every action. Let's go to the next slide. All right, so in the case of hearing loss, have you had any fevers? Have you had any headaches or visual changes? Because this can mean a couple of different conditions. These are important things to let us know if we have some types of infections. Or if we're having something that might be a little scarier than that, like a glioblastoma and just the wrong area. Next slide. All right, tinnitus. That is ringing, hissing, crackling, or buzzing. When did it begin? Well, I've had it since I was 5. Okay, that's probably Meniere's. Sorry about that. I hate it for you. Well, I just had it a couple of days ago, all right? Or I just had it 5 minutes ago. All right, what kind of diet are you taking? Well, I have a high sodium diet. Oh, okay, well, you can't do that anymore because that'll take care of the ringing and the buzzing. There are reasons that we need to know these types of things. A lot of times, medication management can fix a lot of problems, or dietary changes and lifestyle changes. So that's why we ask these types of questions. Next slide. All right. How long have you had an earache? Could it be related to your mouth, your sinuses, or your throat? They're all very well connected. They all tick each other off when one gets really irritated, right? So it's a big deal. Describe the location of the pain. Where is it? Does it refer anywhere? That's a big one, right? Explore things that might potentiate these types of behaviors. Are you a swimmer? Do you scratch your ear with a car key? Oh my gosh, it's crazy, but it's real. I had a patient that did that and burst their eardrum, and it was ridiculous. And it was an Oldsmobile. Oh God. Was it an Oldsmobile Cutlass Supreme? I believe it was. That was the key. That was the key to that car. And I tell you what, I hate to be that car going in that ignition with them ear goops going in there too. I can't get over it. But he was a used car salesman, and he scratched in his ear with his key. And I'll never forget it, because it was like, dude, what used car place was it? Because I would never in a million years go there, just because for whatever reason it just really disturbed me that somebody. He said, yeah, sometimes I use paper clips. I'm like the scoop of the paper clip, like the top rounded part. And he's like, no, I'll extend that one piece out, and then I'll just use that to kind of swirl around. And I'm like, oh my God, please stop talking. Just please stop. Please stop. Because can you imagine how, like, how jagged that end piece of a paper clip is that you extend? It's super jagged, right? Like, if you haven't, feel it, because I have, and don't ask why I know. It's because I wanted to see how jagged it was when he told me he used paper clips. So I actually opened one up and proceeded to poke myself on the dorsal side of my hand and was like, oh boy, that's something, right? Can you imagine the inner ear that's even more hypersensitive to touch? Oh yeah, no, not a fan. Not a fan at all. All right. So this is why we ask these questions. Next slide. All right, again, we're going to ask about pain. When does it hurt? Does it hurt when you pull it? Does it hurt when you stick your finger in it? Does it feel better if you stick cotton in it? Right? That could tell us the difference between classical otitis media and perforated eardrum. Big deal. Big deal, the two. Next slide. So let's talk about nosebleeds. Nosebleeds. When did the bleeding begin? Is it thick? Is there drainage? Is there foul smelling? Is it clear fluid? Do you have a headache when it's going on, right? Thick or purulent, green, yellow, malodorous discharge usually means bacterial infection. You do need to know that. Foul-smelling discharge, especially unilateral discharge, is associated with the foreign body or chronic sinusitis. You need to know that. If it stinks, then there's something foreign in there, and that's why it's stinking. All right, or chronic sinusitis, which means you're blocked up all the time. They call it polypoid as well. Next slide. All right, so let's talk about profuse watery discharge and it being typical with allergies, because it is. Postnasal drip is just watery discharge in the back of your throat that just keeps bobbing up and down while you're sleeping, which is why you cough all night when you're laying down. That's all there is to it. It just triggers that response that makes you cough. Bloody discharge may be a neoplasm, trauma, a fungal disease. It could be because you got into a fight. It could be because you just had your tonsils taken out. I mean, there's a lot going on that could cause all of these things. Could be because you had a post-surgical fix of a deviated septum. I mean, it could be chronic nosebleeds that haven't been cauterized appropriately. I can go on for days. Epistaxis is the word for nosebleed. You need to know that. Yes, thank you. That's correct. Here's how I remember epistaxis. Epi means above, right? And taxis, I think of a taxi. And taxis run everywhere, just like your nose runs when it bleeds. So that's how I remember epistaxis. I don't know if that'll help you, but I felt like that was pretty good. If you have one better, let me know. Yeah, there's that. So, may result from cocaine abuse. I think that's pretty self-explanatory, because cocaine will burn through your nasal passages, physically burn through them. So, yeah, cocaine bad. Bad cocaine. Yeah, next slide. All right, so let's see. Rhinitis, allergic rhinitis. Um, Itching, swelling, discharge from eyes, postnasal drip, and cough. Fatigue, fever, pain may be associated with infection. And again, the pain that's associated with the infection is because it's full of stuff, right? And allergic rhinitis is nothing more than hay fever. It's nothing more than pollinated allergies or things of that nature. The environment usually causes allergic rhinitis. And the way I remember allergic rhinitis is I think about a rhino and a rhino's big old fat horn. And I feel like I have a rhino nose when I have allergic rhinitis because my nose is so stopped up. It feels like it's giant. And I know you guys know what that feels like. It feels like your nose is swollen, and then you look in the mirror and your nose looks like physically fatter. That to me is how I remember rhinitis, because a rhino's horn is huge. That might help. It might not. If you got something better, let me know. Next slide. All right, we're hopping on along, going to throat now. So sore throat, can you describe it? Is there a lump? Is it burning? Is it scratching? Is it painful to swallow? That'll let us know how deep it is. That'll let us know if this is something like tonsillitis or laryngitis. Or if it's something bigger, like strep. Strep sucks. I've had strep throat before. And it was so bad that when I would swallow, it would physically hurt to swallow. And I mean, like, it felt like I was swallowing glass. It was awful. So these are why we ask these questions, because it gives us an indicator of what that looks like. Yeah, so next slide. And again, we're going to want to know, has anyone just recovered from a sore throat? Is this something that's communicable? Communicable means, is it something that I can give somebody else, right? So determine what strategies will work based off of those answers. Are we going to need to get antibiotics for multiple people because we're just going to be passing it back and forth to each other? That type of a deal. Is this a viral situation? Like, what does this look like exactly? Because antibiotics aren't going to do us any good with a virus, right? That type of a deal. Next slide. So oral lesions. Let's talk about oral lesions. Oral lesions are a big deal because most people who have a condition that don't realize they have a condition have some type of oral process. What I mean by that is a lot of people who have autoimmune disorders have ulcers in their mouth. A lot of people who are immunocompromised get thrush. A lot of people who are severely riddled with types of mental disorders like generalized anxiety disorder or panic disorder, things of that nature. They will also have lesions because they chew on their face, and sometimes they can get infected. And when I say chew on their face, I mean they chew on the inside of their cheek to the point where they put a literal hole in the side of their mouth, that type of a deal. Or is it trauma? This is the weirdest mouth talk I've ever had. So I had a patient, check this out, try to picture this in your mind, paint this cartoon. I had a patient who got hooked in the mouth by his father-in-law. Ooh, that's fun. So how did that happen, Molly? I'm glad you asked. So here's what happened. He was out with his father-in-law because he was going to talk to him about, starting a family and wanting kids with his daughter. And this was the type of dad that was kind of a ruffian dad because his baby girl was the best baby girl in the whole wide world. I get that. My dad was the same way. So they were out fishing and he was joking. And he was a really good fisherman. I guess he was like a competitive fisherman, this dad. And he would do a joke. My dad was a pool player on the side. That's how he made some side money. And one of the things he did is he would showboat for money. So he would bet people that he can make these crazy shots, and he would make them all the time. And that's how we would eat for that day. So it was a little crazy. This guy was kind of the same. He was really good at casting, which is where you fling the rod back and then your reel goes through and you got your worm on your hook or whatever device you have and jumps into the water, and that's how you catch fish. Well, he would be able to flip it and cast it, and he'd be able to take off someone's hat, and it was a running haha joke. Well, he was about to do it to his son when his son turned around to go do something, and it was mid-sentence, and it caught him in the side of the mouth and went through his cheek. Right? That was kind of weird. So, that was a day. That was definitely a day, and that's how you can get trauma in the mouth, and the most random trauma you've ever heard of. So there's that. You won't forget it now. Next slide. All right, bleeding, lumps, thickened areas in the mouth are possible symptoms of cancer, period, point, paragraph. Needs to be addressed, needs to be looked at. That's why when you go and get your little dental checkup, they give you numbers. They say 2, 4, 5, whatever it is. And that is your risk for oral cancer in that area on that tooth, right? They do that, I think it's yearly. I don't get with dentistry very often, but you know, it's weird. Doctors and nurses never learn about dentistry. Never. It's the one thing that we never learn. And I've never understood why, because we have so many bar fights in the ED that you would think that we would need to know the mouth, right? Because where does someone go for? Yeah, they go for the head. So I always get a correct occipital, right? That always happens. That's a thing. Because someone gets punched in the eye. And I always get the nice little, broken nose. It's, to the side, kind of, and flattened. And I always get the broken teeth. But we never really do anything for the inside of the mouth because the tooth has already been knocked out. So what are we going to do, right? So it's weird. It's like we have this whole entire body system that's super important, and we just kind of go, all right, well, yeah, you're a nurse, or yeah, you're a doctor. They just don't go over it, and it's super bizarre, if I'm honest. I wish we spent a little bit more time. This is the most time I've ever spent on the mouth ever. And I'm the one teaching. I'm not the student, so that makes no sense. So yeah, we need to ask these types of questions about oral lesions because it might also be indicative of having some type of sexually transmitted disease as well. So we need to double check on that. Next slide. All right, so we need to be aware of our interview questions. They need to be... This kid, she's not getting enough love today. You can hear her in the background clicking things just to make sounds. We need to know the interview questions that we're asking. We need to be cognizant of that because some people take certain questions the wrong way. Some people take certain questions in a literal form, and some people answer them sarcastically. So we have to give them the appropriate interview questions. Why would we ask you a question about your foot if the problem is your arm, right? Anatomic differences. We need to know, is it anterior or is it posterior? Is it, above or below? Is it sagittal? Is it transverse? That type of a deal. Is it superior or inferior? Things of that nature. We need to let them know and be aware of the examination procedures, because if we have a patient who's going to go into a surgical procedure, the first thing they're going to ask you is, what do you know about it? So sometimes my doctors won't tell them anything other than the procedure and what they're going to do, but there's a lot of questions they have in between, and that's where I come in because I am that middleman. So a lot of times they'll trust me with the questions I answer versus what the doctor says he's going to do because they don't understand what the procedure looks like. So I, as a nurse, when I have a surgical procedure and I'm a brand new nurse, I always ask if I can go. Surgeons love to bring in newly graduated nurses and or students, and they love residents too. And here's why: because surgeons are the unsung heroes, right? They're important, but you really don't see them often. And when they're in surgery, they have their little squad, and other than that, they pretty much do their own thing. So when there's an opportunity to bring somebody else into their world to experience it, because it's a whole different beast working with surgery. I've worked with those guys before. Dude, fantastical. I can't wait until we get into the surgery talk because I got buku crazy stories to tell you about that experience. I had a fantastic doc that I work with who was a surgeon. She was she was my age. I just thought she was the bee's knees. I still do. She was out of Galion, Ohio, and I adore her and will always adore her. And she has showed me a wild ride in the world of surgery. So I'm excited about getting to that point. So you need to know these procedures so that you can tell them what they're going to expect. It gives them peace of mind. It helps them calm down, right? It decreases the amount of anxiety medication I have to give them, which is going to do better for them when they go into surgery. If I have them doped up on a bunch of Ativan because they're freaking out about their, amputation that they're having, that's a huge deal, especially with respiratory depression. So that could cause further complication versus me just talking to them and they don't need it. Like, it really is that easy. A lot of complications we create because we just leave a whole bunch out, and it's stupid, and it's a waste of time, and it just ruins it for everybody. And I just don't get why you can't take the extra 30 seconds to say what you need to say. So don't be those guys, right? Next slide. Right, again, we got common problems with conditions of headaches. Most common medical complaint. That is accurate. Recurrent headaches are a symptom of chronic primary headache disorder, or excessive hypertension they're not aware of, or a couple of other issues. So yeah, I'll buy that for $1. Maybe associated with ophthalmic or dental problems. Yes, absolutely. Or chronic sinusitis or infections. Or a tumor or hemorrhage or a million other things. So we can't really say. A headache is the most common complaint because people can usually deal with regular aches and pains. They can't deal with a headache. It's something about the brain causing that pressure in the head that just radiates to your teeth. That pain people can't stand. And usually when that happens, they're coming in and we're finding out, it's something a little more serious a lot of times. One time I had a patient that came in with a recurrent headache, and he was, get this, he used to fix the boilers in 130-year-old homes. That was his entire job. I guess there's a small area of this is like a niche of job where he gets the crust out of the boilers that are these cast iron boilers that heat up the entire house. He scrapes them down from all the coal that's been burned through the boiler through all those years. He scrapes the coal down to the very bottom layer, and then you can use it again, and it can be used for another 100 years, and it's fine. And that's what he does. So he came in with recurrent headaches and thought that he had some issue with the soot or whatever, and it turned out that the soot was infectious fungus that was within the soot, and because he had inhaled it for a period of years, he had a big tumor in his head that was nearly the size of my fist, and we were all going, what in the heck is this? And again, it was the growth of this it wasn't a parasite, it was an infection. It was the growth of this fungal infection that was almost like an abscess. And it was going to be causing him seizure because those headaches that he was having, recurrent headaches and those recurrent twitches, were showing up on an EEG as brainwave abnormality, which means he was headed towards seizure. So again, headaches could be, a million of things. And you have to be able to, again, speak to your patient and hopefully maybe round it down, and you get better as you go. I can teach you nursing all day long from a verbal perspective, but the most of what you learn in nursing is hands-on. 90% of nursing is hands-on. 10% is the stuff I teach you prior. That's why I tell you guys a whole lot. That's why I spend a lot of time doing these lectures. I want to tell you everything that I know so that I can download every bit of information into your head and every bad scenario that I've played out, so that you don't hopefully have to, so that you can save a lot of your soul from a lot of bad memories that you're never going to get out, because they won't go away ever, no matter how hard you try. Maybe for a little bit, but they always come back. And I feel like that's my gift to you for being a part of this craziness that is medicine. So next slide. All right, migraines. It's everyone's favorite. It can occur early in life, late in life. We start with an aura. How do I explain an aura? So an aura is... An aura is a field of energy or light that is about 4 inches to 8 inches extending from every outline piece of your body. So if you fan out your fingers, I'll be able to see it between your fingertips. If you open up your arms, I'll be able to see it through like your armpits. And I wish I had a picture of one. And it's a weird kind of halo that just kind of goes around your entire body. And that's usually the first indicator that things aren't going to be a great day. So then you have a vasospasm of these intracranial arteries. And what it does is it distributes far too much into one area, and we need to not have those areas dilated, because the dilation is what's actually causing the pain. So we need to constrict them, which is why we take medications called Furoset, right? Which is a medication for migraines, which has caffeine in it. And the caffeine will, again, constrict that venous system, and all of a sudden your migraine goes away, or at least that's the theory, right? That's kind of how it works. So what problems do we have? Well, they last for days. That is an accurate statement. Cold, dark are our favorite things, because, you have photophobia and nausea, and cold helps that. Depression, yeah, you can't frickin' move. It sucks. Restlessness, yeah, you can't get comfortable because your head is in a vice grip and it runs all the way down into your muscle group sometimes. Irritability, I've known some people that have had complex migraines. We thought they were having a stroke because they weren't able to physically speak, and it was because their migraine was so severe. They weren't able to appropriately move one side of their body. It was unilateral. We thought, oh my God, they can't move their arms. This is a stroke. No, it was a complex migraine. Some of these guys can get really, really nasty. And then some can be like, meh, bah, whatever. No big deal. So it just depends. Again, most of anything in the world that you find, you'll find is a spectrum. It's a thing. It's a revolution. We're here and we're not going anywhere. It is what it is. And that's how we need to look at things. And it's okay. It's perfectly okay. Let's go to the next slide. All right, what are we talking about on this slide? Cluster headache. Okay, yeah. Most people have the primary headaches because it's acute. Remember, if I have migraines are dull. They're miserable, don't get me wrong. But a cluster headache is far worse. I've had both, unfortunately. Cluster headache's the worst one I've definitely had, for sure. Last 30 minutes to an hour. Yeah, mine lasted a little bit longer than that, but I'll buy that for $1. Pain is burning, drilling, stabbing behind one eye. Your teeth hurt. Your physical teeth hurt. Let's see, you could have unilateral ptosis, yeah. You can have dysfunction of your lacrimal glands. You could have stuffiness. You can have drainage. You can have a whole bunch of stuff going on with these cluster headaches. They're pretty nasty things. Next slide. All right, tension headache. I always remember tension headache in the ages because it's between the ages of I'm still trying to figure out if I'm going to end up in jail. That's the 20-year-old mark. And then the 40-year-old mark is I finally found what I'm supposed to be doing in my life, and I finally got a career, and I'm finally settled down. That's the period of having tension in your life. So those are the tension headache years. That's how I've always looked at that, because when you're 20, you don't know any rhyme or reason or what you're doing or how you're doing it or what you're even going to be when you grow up, because you don't even know if you want to grow up. And then when you hit 40, you have finally admitted the fact that you have to grow up and you have to be a big girl or big boy, and you have to start being stable. So there's that. So all of your crazy time that you had during these years and all the mistakes you made and all of the bluffs you took and all of the gambles you made, that would create the tension headache because you're going in through a lot of turmoil, right? It's in the front temporal parietal or occipital areas, which means it can be anywhere. The onset may be gradual. It may last for a couple of days. It might also have a jaw or neck or face stiffening or contraction component that goes along with it, which is never good. Feels like a tight bend is around their head. I know what that feels like for sure. And it's scary because it involves all these pieces and parts, and you always think when you have a headache and something's happening and you have any jaw pain and you're female that you need to run to go find out that you have a stroke. So a lot of people come in with tension headaches after days and they think they've had a stroke. And even though I laugh, I'm just so grateful that they haven't had one that it doesn't even matter, and they feel silly, and it's nothing to be feeling silly about. I get it. It makes sense. So that's a tension headache. Next slide. Okay. Post-traumatic headache. This is a real thing. This actually happened to a girlfriend of mine that I went to school with in my bachelor's program. It is secondary to a headache or concussion, or a head injury or concussion. So it's usually caused in a motor vehicle accident. This one happened in a motorcycle accident. She dumped her bike and she did not have a helmet. And when she dumped her bike, She cracked her bike on this, or she cracked her head on the side of the pavement. Pretty bad. She recovered fine. But here's the weird part. As a result of her dumping her bike and breaking her collarbone and doing a whole bunch of other things to her, she also had a residual effect neurologically. So I would be talking to her, and all of a sudden, it would be like she had ADHD. She wouldn't know what was going on or what I was asking her, and she'd ask me what I just talked about, and I'd look at her funny, wouldn't think anything of it. Then she would have these extreme periods of just being goofy. I mean, like hysterical loony bin, Willy Wonka, Johnny Depp, with the melting animatronics, right, in the very beginning of the scene when they first go to the factory type of giddiness. It was nutso. And then sometimes she would get dizzy and grab a hold of me immediately. She would walk and everything was fine, or she'd stand still and everything was fine. And she'd get mid-sentence and she'd get dizzy and have to snatch on to me. And I used to think, this is a gross exaggeration. No, it was a thing. It was a thing that went on for years. And sometimes that happens. So that's why post-traumatic headache is such a big deal, because the residual effects might be worse than the trauma itself from the original damage that was done. Next slide. All right, so let's get into hydrocephalus. Hydrocephalus is an abnormal accumulation of cerebral spinal fluid. May develop from infancy to adulthood. So usually it's because of an obstruction. And what we do is we usually give them a shunt, and then it drains into their belly. However, there are a lot of pieces and parts that are added into it. But by and large, these are the guys that have the hydrocephalus, especially the babies. They're the ones with the overly large heads. And as you become an adult, it becomes more of a problem because those sutures are closed, that intracranial pressure doesn't have anywhere to go, and then we start squishing brains, right? So that's why it's such a big deal. Next slide. All right, so we have chalazions and Hordelians, or styes is how you pronounce it. So chalazion is a nodule of the gland of the eyelid. It's going to be very tender. It often follows conjunctivitis or any types of cysts. We rarely talk about these, if I'm honest. Stye, we talk about more often because everyone's dealt with them before. They're usually painful, they're red, they're edematous, they're a mess. They cause a lot of watery eye, they cause a lot of pain, they cause a lot of irritation, and warm compress is usually the cure-all for that. And time. And taking care of yourself, basically. So there's that. So yeah, I got nothing else for this slide, so we'll move to the next one. All right, so now we're going to talk about conjunctivitis, and conjunctivitis is inflammation of the conjunctiva. The eyes are going to be red. There's going to be thick, sticky discharge. You're going to have trouble opening your eyes in the morning. It's very annoying. It's very awful. We've all seen conjunctivitis. Obviously, there are measures you're going to have to take to keep things clean so that you are not passing it along to people. This is the daycare disease. If one gets them, they all get them. So that's about all I'll say about that for right this second. Again, it can be an allergic reaction. It could be a bacteria. It could be a virus. There's a lot of things that can cause it. It's just, again, inflammation of the conjunctiva. And that's about it. So next slide. All right, so here's a term we're going to need to know is strabismus. It's a abnormal ocular alignment. They do not meet the visual axis at the desired points. So it's because of muscle weakness. It's because of focusing issues. It's motor imbalance sometimes. So the most common types are inward turning eye, or what they call the lazy eye, or the cross eye. You get it a lot with infants when they're first born. They do those weird wonky eyes. Or you could have extropia, which is where the eye turns outward. So estropia turns inward, extropia turns outward. Do you need to know that piece and puzzle? Not necessarily, no, but you need to know what strabismus is. So we'll go to the next slide. All right, so now we're going to talk about a condition called pterygium. But it's PT. Yep. So is pterodactyl. All right. So pterygium is a non-cancerous growth within the conjunctiva. We don't know what causes it. It's a lot of times associated with major sun exposure, major wind exposure. It's seen in older adults. There is usually inflammation or what feels like something constantly in the eye, and that's the lesion itself. White tissue with blood vessels on the inner or outer edge of the cornea. Have I ever seen a case of this? No. Am I ever going to see a case of this? Probably not. Just because it's not something that even if I did see it, I would recognize it, because it's not something that we would clock in an in-house situation, because we work on the acute issues and then we send them home for follow-up. So in my line of work, with my line of nursing, this isn't something I see often, but it's something that you need to know exists, and I would give it a Google and then move on. Next slide. All right, cataracts are pretty common. Cloudy or blurred vision, because it causes this opacity of these, it's like a crystalline area, and that protein causes the denaturation of that lens. All right, so basically it's a cloudy blur, right? Causes diplopia or double vision. Poor night vision also comes with it. Frequent glasses changes comes with it, things of that nature. You can clearly see the cloudy lens when you look into the eye. And then the red reflex might not be there because it can't penetrate the opacity of that white film. Next slide. All right, so diabetic retinopathy, it is problems with diabetes. It causes the retinal capillaries to basically shut down and shut off, and it causes blindness eventually if it gets bad enough. So they report a decrease in vision, they have a background of it, or microaneurysms or hemorrhages. Sometimes there's exudate. It's kind of a mess, and they immediately need to start intervention on helping their diabetic process so that they can better manage it, so that they can at least slow down this process. Next slide. All right, glaucoma. Glaucoma comes up a lot. Two types of glaucoma, open angle and closed angle. It's created by the iris and the cornea of the iris, actually. It is an intraocular pressure problem. It leads to blindness. It is incredibly painful. You have to give these guys their eye drops when their eye drops are due. These people are used to these eye drops at this time. Most nurses will not give eye drops because if they don't have to go in there to give them any other meds, they're not going to drop in there to go give them eye drops. Only if this person has glaucoma, this will prevent the pain because it is also getting rid of that pressure, that interocular pressure, because of the type of medication that it is, which you will learn about in pharm. So yeah, it's a big deal. And it can be a bigger deal if it's not taken care of and managed. And eventually you're going to go blind if you don't fix it. So sharp eye pain. You see a halo around lights. That's the first indicator that you have this problem. There is a hereditary component with glaucoma. There's also an environmental component with glaucoma. So there's a lot of education to give people with glaucoma. And we will continue to talk about these things as we move on to Med-Surg 1, Med-Surg 2. We're going to get into what exactly happens with open angle versus closed angle, so you get an extra layer of what that looks like down the road. Next slide. All right, foreign bodies in the ears. People put toys in their ears. People get stones in their ears. People throw all kinds of stuff up their nose and their ears and everything else in between. It's a lot. So yeah, it can feel full. It can feel like you're losing your hearing because something's occluded. It can feel very itchy or scratchy. Sometimes there's live insects and they move around trying to get out. It's a whole thing. There's foreign body components that could be potentially dangerous, like if someone sticks a stick pin in their ear, which has happened before, and I'm just like, why? Because it itched so bad and that was all they could find. Oh boy. So yes, problems and conditions with ears are usually related to foreign body for the most part, or, inner ear infections. So next slide. All right, so otitis media, hooray! It's an infection of the middle ear. It has ear pain, or otalgia. Let's see, fever, vomiting may be included. Yep. Decrease in hearing, absolutely. Early stages, you got a red, swollen, inflamed, bulging tympanic membrane, which looks really nasty and it's awful. Later stages, there may be some discoloration with some drainage, because at that point it's just begging to get out in the only way it can. And purulent drainage from the ear with sudden relief of pain. So I get drainage and pressure and it hurts, and then all of a sudden, all better. That usually is a perforation, which is never a good thing. So that means the eardrum has a hole in it, and it's going to need some tender loving care while it grows back, and it usually is about a month-long deal. Next slide. All right, additionally with this problem, you're going to have the feeling of being clogged. There's also going to be clicking or popping, or I hear what sounds like someone rub a newspaper right to my ear. It's annoying. I can't stand it. And it also makes you incredibly dizzy sometimes. So yeah, the tympanic membrane or that eardrum is often retracted and yellow or gray in color with limited mobility, because, again, you have a middle ear infection and it's quite painful. So next slide. Okay, so conductive hearing loss is a little bit different. It results from blockage of the external auditory canal. So you're going to also potentially have problems with your tympanic membrane. You're going to have decreased ability to hear. You're going to hear muffled tones in a lot of things. Sometimes the hearing problems aren't necessarily visible, so they don't quite catch it the first time, and they have to do follow-ups over and over, and this might happen a couple of times before they finally are able to figure out what it is that's causing this conduction hearing loss. Next slide. So sensorineural hearing loss is caused by structural changes. 90% of them are hearing loss. That's the reason for hearing loss. So 90% of the people who have sensorineural hearing loss have that type of hearing loss versus the other types of hearing loss, right? Usually it has to do with the atrophy or deterioration of the cells in the cochlea, and that would cause degeneration and a stiffening of the cochlear motion, which is not going to catch those vibrations as well, because remember, vibrations are waves, right? And if it's too stiff to receive that, then it's going to receive only pieces and parts. It is usually gradual or progressive bilateral deafness with the loss of high-pitched tones. Again, we see this in the elderly, specific to losing the high-pitched tones factor. They have a problem filtering background noise. It all sounds like the heightening of a sound, like a louder sound that still is muffled. And it's very frustrating. And a lot of times there's not a whole heck of a lot you can do about it. But that's sensorineural hearing loss in 1 minute and 15 seconds. Next slide. All right, so let's talk about epistaxis. Again, it's bleeding from the nose. Super common. Happens for a lot of things. Picking your nose, coughing, trauma, sneezing too hard, trying to cough up your spit when you have some type of like bronchial infection, and you try to get all your saliva through your nose passage, and you make that awful sound that I'm not going to make right now. Again, it's bleeding due to the high vascularization of that area. It mostly occurs in the interior or in the septum, and it bleeds, and a lot of times it needs cauterized, or a lot of times, we will put a device in there, like a nasal trumpet, to stop that bleeding. Sometimes we just use a tampon because that's all we have. But yeah, that's epistaxis. That is a nosebleed, in its true form. So let's go to the next slide. And again, we talked about allergic rhinitis. I said a rhino has a big horn. It feels like you have a big fat nose when you have allergic rhinitis because it's inflammation of the nasal mucosa. Long histories with allergic rhinitis in families run into their children and their grandchildren, so it's pretty normal. This is sensitivity to inhalants, so dust, seasonal pollen, things of that nature. You sneeze, you get itchy eyes, they're watery, they're red, you get drainage, right? It just feels awful. And a lot of times we give loratadine, which is a medication, and fluticasone, which is a nasal spray. So it's like a Claritin and a nasal spray, and that usually fixes the problem, and you're good. Next slide. All right, I got 10 more slides to go, and I'm trying not to stumble over my words, but when you've been talking for 10 hours, it's a lot. And hey, guess what? It's almost 7 o'clock, where I do Zoom from 7 to 11:30 on today, so that's going to be fun. But hey, digressing, we're almost done. I'm excited. So acute sinusitis. It is an infection that is a result of pulling secretions within your sinuses. So throbbing pain is what you see in these patients. It is thick. It is purulent drainage. You have arrhythmia. Or erythema. Right? You're red. You're swollen. You feel like crap. Your nasal mucosa is just red and nasty. Right? You have just a terrible, terrible feeling all over, that everything is just full and your head is banging if you have any pressure to it. Again, there's medications that stop this, but please understand the difference between this and allergic rhinitis. Next slide. All right, so herpes simplex 1, or a cold sore, highly contagious. It's a viral infection. It's spread by direct contact. You get, burning, tingling, pain before the lesions kind of move about and spread. They're on the lip. They're on a big fat group sometimes. They form crust. They have pustules. They go from vesicles to pustules to crust. And they're just a nightmare, and they hurt. And everyone knows that because everyone's had one before, basically. So yeah, that's herpes simplex 1 is a cold sore. Next slide. All right, about a million slides ago, we talked about the mouth, and I showed you the diagram of the mouth and the pieces and parts that we would care about. The gingiva is one of them, and gingivitis is the inflammation of the gingiva, right? So poor dental hygiene means that there's a bunch of plaque on the surface and at the gum line, and it's really in between the gums as well. It causes really nasty inflammation, and it hurts. And when you brush your teeth, your gums bleed. And it stinks. It's got that weird stinky smell, because you don't floss your teeth and get in between all of the pieces and parts. So those food particles stay in those areas, and then it decays and it smells awful. So most people with gingivitis have really kind of bad breath, like really, really bad breath, like not like coffee breath, like really, really bad breath. So it's incredibly painful for them. So they have to teach their gums to stop bleeding, and they have to start doing some pretty serious flossing and keeping up to that regimen religiously, and it gets better. Sometimes medications have to get involved. It just depends. Next slide. All right, so tonsillitis is commonly found in bacterial pathogens, beta hemolytic, and other streptococci. Now, if it's group A strep, at that point, it no longer is tonsillitis, it's strep throat. Group A strep is the only one that is specific to strep throat, and that's why the tonsillitis then becomes strep throat, because it can predicate from an origin that starts off as a tonsillitis, right? Because what is tonsillitis? It's just an inflammation of the tonsils, right? So classic presentation: sore throat, you betcha, fever, chills, tender, cervical lymph nodes. You just feel icky all over. That's the word malaise. You just kind of feel run down and achy everywhere. That's just ugh. That's what that is. So your tonsils are red and enlarged. If you're group A strep positive, then you definitely have the patches of white in the back of your throat. And that is a pretty tall tale indicator and textbook example of what that looks like. So next slide. All right, another big word, candidiasis. Candidiasis. Candidiasis, thrush. It is an oral infection caused by Candida albicans, and it's in immunosuppressed people, or it's a result of antibiotic therapy, or people who are chronically debilitated get it. It's white. It's like a second layer of skin. It's so thick. It's like a white plaque on your tongue, and you can scrape and scrape and scrape, and you'll maybe get a little bit out. Sometimes it's so thick it peels, and it's a little bit easier, but it gets really attached to the surface of your tongue. So it's hard to get rid of the white patches until obviously you take the medication. But you can, like I said, scrape and scrub, and it doesn't really do most of anything. It also is in the buccal mucosa, which is the inside of the cheek. Sometimes it's in the posterior area. I mean, it's just nasty. Like I said, oh yeah, there's my next bullet. I'm not even looking at the bullets. I'm watching this stuff on TV that my kid was watching earlier. So I didn't see the peeled off part, but yeah, it's raw. It bleeds. It's swollen. It's hot. It's red. It's ulcerated. They cannot eat. It hurts. It hurts to eat. So we get the magic mouthwash because it's got a lidocaine in it. And it's soothing to them. So they use that for pain management, and they also use a regimen of medication to kill thrush. And I will let pharmacology introduce that to you, because I'm not going to sit here and confuse you and add on more things that don't need to be added on right this second for this class. So next slide. Okay, so we have a canker sore. It's common. Lots of us get it. 30% adults, 30% of school-age children get it. They're painful. They're usually on the inside of the cheeks, the lips, the tongue, the palate, sometimes on the gingiva. It just depends. They can last a couple of weeks. They are related to increase in stress and cortisol dump, and other things of that nature. They're usually soothed with gargling salt water that's warm. That's usually our recommendation for, just kind of getting through the ease of it all. Also, not eating ketchup. I learned that the hard way when I was a kid. So yeah, that is an ulcer, or what they call a canker sore. Next slide. All right, oral cancer on the lip, within the oral cavity or the oropharynx. They are tiny lesions. They're usually asymptomatic in the early ages. That's why they're so scary. Red or white patches can be seen. They're usually painless. Or they're painless, and their ulcers just stay and they never quite go away. And they build a different type of tissue because it goes into the cell itself, goes into a metamorphosis and changes the structure of the cell itself, which makes it this kind of wonky cancer cell type of a deal. So bleeding, loosening of the teeth. Difficulty wearing dentures because of the lesions and the pain appropriated with it or associated with it. Difficulty swallowing sometimes. These things can get pretty big and pretty nasty, and sometimes we have to remove the entire jaw, the bottom jaw. Ebert and Ropert, I can't remember which one it was, that was the movie critic that had his bottom jaw removed due to oral cancer. So there's that. If you ever want to give that one a Google, you could see what that looks like post-surgical. But he had a very wonderful existence. He was a very wonderful man and did a lot of great things for the community, and was kind of a all-around, all-about kind of guy. So good for him. So let's move on to the next slide, because I honestly don't have a whole heck of a lot to talk to you about with regard to oral cancer, because again, it's not something that we're going to be addressing, at least from a bedside perspective in an acute care situation. If you're in an LTAC or if you're in an ECF, that might be something that might be a little more concerning. That's something that you would see more often, but it doesn't happen often enough in my world to be able to tell you a whole lot about it. So we'll go to the next slide. All right. So there's two diseases regarding thyroidism. There's hyperthyroidism, there's hypothyroidism. There's two main thyroid disorders that always get mixed up. Graves' disease always gets mixed up with Hashimoto's. Here's how you do this. Grave. This is hyperthyroidism. So how am I going to remember hyperthyroidism? Well, here's how you remember it. Sympathetic versus parasympathetic. If I am hyperthyroidism, then that means I am going to have a hyper reflex and a hyper dump of that hormone, which is going to cause me to have a higher heart rate, to be a little bit thinner, to have a pretty swollen thyroid, I would say. I would be very mentally kind of pinging all over the place. All right, that's kind of the vibe you get. And what I say is, I'm going to run myself into the grave. That's how I remember Graves' disease. It is a familial autoimmune disorder. It is the most common cause. And then when we talk about Hashimoto's, Hashimoto is a Japanese name. And I always like to think of the Japanese in respect for one another. They bow to one another. And you're bowing down because it's hypo. We're going down, hypo. And Hashimoto, again, a Japanese name. We bow down. Done. So that's how I remember the two, to keep it in order in my brain. I don't know if that'll help you. I would encourage you to do that because it's always helped me and I never forget. And whenever someone says Graves' disease, a part of my brain always goes Hashimoto, aha, right? And I'm like, all right, that's right. It is Graves. Perfect. Because I'm going to run myself into the grave. So yeah, there's the two. And there's a lot of pieces and parts to this. There's a lot of thises and that's, a lot of pathophysiology. Like I said, I'm not here for that, not for this class. If I need to come back and explain that to you later, I'm happy to do it. But for the purposes of right now in this class, we do not need to go there. We are not going to go there. But you'll learn that starting next semester in Foundations, a lot bit more in Med-Surg 1, and then a ton more in Med-Surg 2. And then by Capstone, you should have everything you need. So at that point, it's just maintenance. And then you guys are done. See how easy that was? That fast. So let's do the next slide. We're almost done. All right, so hypothyroidism is decreased production of the thyroid hormone. So these are the etiologies. This is the reason for this happening. That's what etiology means. So why is this happening? It's happening because of atrophy of the thyroid gland potentially. It's happening because of iodine deficiency potentially, right? So what happens when this is happening to a person? So decreased metabolism. Think about that. Low energy, low frequency, low vibration. So if my energy is low, I'm going to have decreased metabolism. Duh, right? Patients seem to be in slow motion with a depressed effect. Again, here we are with that type of instance. A goiter may be seen with hypothyroidism. A goiter is, and I want you to look it up, give it a Google, Goiter. It is a big swollen lump, right? It's just a very, very large lump on your neck. And it's a result of this being just dysregulation of your thyroid hormone. So you have this big bulge in your neck that builds up as a result of that. And they get pretty gnarly sometimes. So give it a go, give it a look so you can remember goiter, hyperthyroidism. Okay, cool. So let's go to the next part, which looks like it might be no, it's not hyper, it's going to be thyroid cancer. So let's talk about thyroid cancer next. Okay, thyroid cancer. It is the most common type of endocrine malignancy, okay? It doesn't cause symptoms very often. Usually is discovered as a small nodule in the thyroid. As it grows, it changes the voice. You have problems swallowing, breathing. You may have an invasion of that tumor into bigger areas potentially. It's pretty scary. The good news is thyroid cancer is probably one of the better cancers to have. It's a quick fix nowadays, and irradiation used to cause it a lot of times. Back in the 90s, we would irradiate people with imaging for practically anything. It was just the answer to everything in the whole wide world, and that overexposure to the radiation from the CT and those components would cause the dysfunction and cause the cancer. So again, it usually, if you were to have a cancer, this would be one of the ones that you would be more relieved to have, quite honestly. But it's still very scary because it can get into later stages. It can cause some pretty tragic things to happen if you let it go too long. So you have to get it looked at and you have to face those demons, bottom line. So let's look at the next slide, and I think we're going to talk about lymphomas, and we're just going to introduce that there's a lot going on with lymphomas, a lot of different types. It gets super confusing when we get into hematology. Today is not the day, so don't stress over it, just learn. Learn and enjoy. Next slide. Lastly, we're going to talk about lymphomas. Lymphomas, they're a group of disorders of the lymph tissue. They're usually hallmarked by very, very, very enlarged lymph nodes. That usually brings you into the doctor because you have one unilateral lymph node that's the size of a softball, and you're like, what the heck is this? And it kind of comes out of nowhere seemingly, but it doesn't hurt. It feels very rubbery. If you were to blow a balloon, not to actually stretch the balloon, but if you were to just blow into it to make a teeny tiny balloon and just have that original rubber balloon, if you just filled that pocket of air, if you tied a knot on that and you rolled it between your thumb and your forefinger, that is the texture that it's going to have within the tissues. That's what I mean by rubbery and spongy. That's the exact feel of it, 100%. So imagine what that feels like, because I know you guys have done that. You started to blow a balloon and then someone stopped you and you had to talk. So you saw it just barely inflate, but not actually stretch it. If you cap that off right there when it's completely inflated before it stretches and you roll it back and forth, that's the feel. Again, cervical lymph nodes get really, really big. Hodgkin's is a different type of malignant lymphoma. It's painless. It's progressive enlargement of that tissue, and it's a big deal. It also causes enlargement of the spleen, which is also a big deal. When we talk about lymphomas a little more in depth, I'll get into that with you. I think we got 2 questions that we have the opportunity to answer if we look it up or if we do a little bit of work. Then we can move on to our next bit of lectures, and I will see you guys later on tonight for Zoom. All right, so first question: as the nurse assesses facial symmetry, a significant finding is. Now, let's break down this question, because I've had many of you guys say, I don't know what's going on with these questions because I don't understand why they would ask them. So here's the deal. As the nurse assesses facial asymmetry, so what this means in plain English is the nurse is looking at the person's face to see if something ain't right, okay? A significant finding is, so what they're asking for is, what do we need to be afraid of? What is something that is not normal? What is it? What is not normal, respectful to the asymmetry of the face? So here we have options A, which is ptosis. We have pseudostrabismus, we have widow's peak, and candidiasis. Well, first off, I know that candidiasis is thrush. So that's got nothing to do with facial asymmetry. So knock it out. Kick it out right there. A widow's peak is the Eddie Munster from, the name escapes me. The Munsters, duh. Eddie Munster, the Munsters, which was an old show that was a derivative of the Addams Family with the Frankenstein added in. It was pretty cool if you want to watch it. So Eddie Munster was classic at having this huge widow's peak, and basically it just is a different type of hairline. There used to be an old wives' tale about widow's peaks. It doesn't matter, but it has nothing to do with symmetry of the face, so you can knock that one out. Now, pseudostrabismus, that's interesting. However, we have the word pseudo, and whenever there is a fold that makes one's eyes look as if it were off center, it would be called pseudostrabismus. Case in point, I have pseudostrabismus. Lots of people do. But I had pretty significant pseudostrabismus, and it is on my right eye when I get tired or when I get super confused about something, or I can't get a word that I'm searching for because my brain's running too fast or whatever. You will see my right eye slightly go into the center, and it's not that I'm cross-eyed. It is literally that angle that I'm at, that fold that I have. It's called an epicanthal fold. I believe that's what it's, yes, epicanthal fold. The epicanthal fold makes one eye look as if it were off center. So in that certain angle, I look like I have a lazy eye, and it's super bizarre, right? So it's not pseudostrabismus. So it would be ptosis, and ptosis is the asymmetry of the upper eyelid. So if it's present, one eyelid could actually droop over the iris of the eye more than the other eye, which would cause facial asymmetry. So what this is asking is, the nurse is looking at a person's face, and something that would be an abnormal finding of symmetry would be asymmetry. Which one of these causes asymmetry? And ptosis is going to cause asymmetry. So A is your answer. Let's go to the next slide and do that one too. All right, so on inspection of the oral cavity, the nurse knows that, let's see, Kaposi sarcoma can present on the palate of the mouth. Oral cancer is often painful on the initial presentation. Ulcers are often painless lesions that usually are only seen in adults. Patients with cancer cannot have candidiasis. Okay, we know candidiasis is from immunosuppression. So first off, that one's gone. D is out of the door. I don't even care about that. Ulcers are often painless lesions that are usually seen in adults. No, we know they're done. They can be done with children. They can have them in adolescence. All right, cool. We were all in high school. We had them done. Kick C away. Oral cancer is often painful on initial presentation. No, on initial presentation, oral cancer a lot of times is painless. Remember? That's why it takes so long for them to figure it out, because there's no pain at all in the beginning. So that just leaves Kaposi sarcoma can present on the palate of the mouth, and it can. It absolutely can. It can present on the roof of the mouth as raised bluish lesions. So there you go. That's the answer to that one. So, all right, I will start uploading this video and exporting it over into an MP4 file and get this video shot out to you guys so you can enhance your learning experience while you are studying your comprehensive overview, because that is what matters for your material for your exam. I love you and I'm proud of you all. You're going to do a great job. It's going to be okay. And I will see you on the other side. See ya.